As many of you know, and as I think I've spoken about before, the agency kind of lost its way in the last several years fiscally. And that creates a number of problems for providers, for the folks that we provide services to, and most important, and members of the General Assembly when they're doing their budgeting, trying to figure out how much money they're going to spend on education versus how much money they're going to spend on Medicaid. So today we will hear from our divisions and their directors. The agenda is posted all around the room. Our focus today is on the operations for 2025, not the budget for 2026. There will be a time for that discussion. That time is not today. If you have questions during the course of the presentation, write them down, find Marcus or one of the other staff people, and make sure they get them. You can also, if you are listening online, there's also a mechanism for you to ask questions in that format. So again, thank you very much, and I believe Sunshine is first up today with the quarterly financial review for DFR. Sunshine, if you would introduce yourself and your team. Thank you.
Good morning. I'm Sunshine Beam. I am the Director for the Division of Family Resources. This is Kevin Eustace. He is the Division of Family Resources Controller, and David Smalley, who is the Deputy Director of Policy at DFR. And I guess we'll jump right in. The Division of Family Resources is the division of FSSA that administers SNAP, TANF, Medicaid, burials, the refugee program, and the impact program. So I'll turn it over to Kevin. Here's an outline of what we're going to go over today. We're going to start with the SNAP. Here you go, Kevin.
Okay, the first slide here is just the DFR's financial summary. You'll know there's two charts, and when we go through, you'll see on the program side of the fiscal that there will be two charts. The top chart is showing the expenditures, and then the bottom chart is showing the funding that's funding those expenditures, whether that be state or federal. So in the columns, you'll see the first column is showing the current month expenditures of March. Then we have the year-to-date expenditures July through March, the forecasted expenditures for the remainder of the year, the total forecasted expenditures that we plan to expend, the funding available, and then the funding balance that we're projecting at the remaining of the year. So looking at the year-to-date expenditures overall, we're at $1.5 billion, and just to kind of make a side note though, the bottom SNAP, Nutrition Assisted Benefits, that's just a requirement that we have to do for our A133 report. We have to record those that are coming in per SBOA, but we don't actually have expenses for the benefits. So the forecasted expenditures for the remainder of the year is $477 million. Total forecasted expenditures is $2 billion. Total funding available is $2 billion. And then overall, we're projecting a shortfall of $24.5 million, which we'll cover more in detail in the coming slides.
We'll jump right in. The SNAP program, the Supplemental Nutrition Assistance Program, provides food assistance to low-income individuals. It is a federal aid program administered by the USDA Food Nutrition Service. Benefits are provided on an electronic card, is used and stored like a debit card and accepted at most grocery stores. As Kevin stated earlier, the benefit is 100% federally funded, so that does not come out of the state budgets. However, the administration costs are split 50% to the state and attributed 50% to the federal government. These are our SNAP program metrics. So you can see the average number of recipients we had per quarter. For the most recent quarter, we had 597,503 recipients and about 285,000 households. And then you can see the number of applications that we received year to date, the number of applications we've received for SNAP has been 359,197. This is the issuance for, so far in SFY 2025. Through the third quarter, we have issued almost $1.1 billion in SNAPs into the Indiana economy.
Here's the program summary for the fiscal. The year-to-date expenditures is $3.3 million. We're projecting for the remainder of the year $1.1 million. The total projection is $4.5 in expenses, and our funding available for SNAP admin is $5.9 million, and this is funded 50% state and 50% federal. And next is our SNAP impact. The year-to-date expenses is $4.1 million. The forecasted expenditures remaining of the year is $1.2 million. And then our total forecast expenditures is $5.4. And then the funding available is $6.4 million.
Sunshine, could you explain what SNAP impact is?
I will let Dave explain what SNAP impact is.
Yes, it's the, there's an employment and training piece to our SNAP program. It's voluntary currently, and participants can come in and express interest in receiving work-related employment training supports. They would be referred to our statewide contracted service provider, EQUIS. They would receive an assessment orientation and then receive job skills training services. They may need high school equivalency services. And then we provide supportive services as well, such as transportation and uniforms and things like that. So,
Thanks, Dave.
Next is our EBT program. The year-to-date expenditures is $525,000. Forecasted expenditures for the remainder of the year is $171K. The total forecasted expenditures is $697,000. The funding available for this program is $247,000. So you'll notice here that we're showing a shortfall in the funding available, and we plan on covering that through other sources, whether that be carry forward funds. We have some expenses that weren't accounted for the last biennium budget that occurred that we had to have funding, find funding for.
And Sunshine, what does EBT stand for?
Electronic benefit transfer, and that is the mechanism with which individuals get their SNAP benefits. DFR also administers the TANF program, which is a temporary assistance for needy families. It provides cash assistance and supportive services to assist families with children under age 18 and pregnant women. The addition of pregnant women happened in last legislative session, so this is new this fiscal year. The goal of the TANF program is to help individuals achieve or return to economic self-sufficiency. As a condition of eligibility for TANF, adult applicants are required to attend applicant job search orientation and complete job search activities. And if they do not complete that, then their application for assistance is denied. And here are our TANF program metrics, and you can see we have approximately 13,000 individuals on TANF, and that is a combination of adults and children. You can see by this slide, most of the individuals served by the TANF program are children. There are 10,213 children average per quarter that we serve in TANF, and you can see the year-to-date issuance is just a little over $20 million that we issued, and these are this is a cash benefit. TANF is provided to the states in a block grant, and then the state administers that.
So going over the fiscal for TANF, the year-to-date expenses is $158 million. Our forecasted expenditures for the remainder of the year is $10 million. Total forecasted expenditures is $169 million. And the funding that we have available that we budgeted for specifically for the TANF DFR is $173 million. This isn't capturing any funding that we're giving out to other agencies, though.
Sunshine, would you mind just taking a moment and describing what other services the state provides using TANF funding? Just a sampling.
I'm actually going to turn it over to Dave. That's why he's up here.
Yes, with the Black Grant, we are allowed some flexibility in funding different programs. There are a number of programs we fund through, or assist in funding through Department of Child Services, DCS, their Healthy Families program in particular. There also is Department of Workforce Development, their JAG program, Jobs for America's Graduates. So when you hear those programs, you don't necessarily think TANF, but TANF is funding a part of that program behind the scenes. So those are several of the programs. We also have had services in the past assisting fatherhood programs and programs such as that in the community. So we do have some flexibility. It has to meet one of the 4 purposes of TANF, and a lot of those services need to focus on the family itself that's in need. So if it meets one of those purposes, then we could potentially fund it.
And Sunshine, am I correct in remembering that this comes out of the 1996 Welfare Reform Act?
Yes.
Thank you.
Division of Family Resources also administers the Impact Program, which Dave talks a little bit about, but Impact, as he described, Impact aims to help participants achieve their economic self-sufficiency through education, training, and employment services. These services are available for individuals who are SNAP and TANF recipients. You can see on average, we serve about 1,400 individuals across both programs in the Impact Program. I'm sorry, this is the number of Medicaid Medicaid enrollees. As you can see in the third quarter, we averaged just a little less than 2 million, 1.9 million individuals on TANF, and those are adults and children. That is everyone. You can see we received through the SFY 25 a total of 529,000 applications and did just a little over 1 million redeterminations so far this fiscal year. Division of Family Resources also administers a refugee program. The Indiana Refugee Services provides assistance and services to refugees and asylees and certain Amerasians, Afghan, Ukrainian immigrants, Cuban, Haitian entrants, and victims of human trafficking. We collectively at DFR refer to these as refugees. The program monitors, perform planning, provision of services, provides technical assistance to ensure compliance with federal and state regulations. All individuals served by the Indiana Refugee Services have legally entered the United States through the applicable federal programs. These are our refugee program metrics from the federal fiscal year, because that's how since this is a federal program, it operates on the federal fiscal year, so it looks a little bit different than our other slides. You can see from October to present, we have received 918 refugees in Indiana. You'll notice for February and March, that number is 0, and that was because there was a hold placed on the program at the federal level. So Indiana has not received any refugees in February or March.
So looking at the fiscal for refugee, the year-to-date expenditures is $30 million. Forecast expenditures for the remainder of the year is 9.8. Our total forecast expenses is $40 million, and then funding available is $39.7 million. And then if you look at the middle, the RCA and the refugee medical assistance, that's coming out of our cash and medical budget, which some of our recipients were higher coming in the very beginning of the year, but as Sunshine was saying, that we're not getting any refugees as of right now, any additional ones, but We just submitted a request to OR1 to get additional funding for the shortfall that we're projecting last week.
The burial program administered by the Division of Family Resources was established by the state to help with burial costs for individuals who are eligible in specific categories of Medicaid. Those categories are listed there, so Medicaid for the aged and disabled, Medicaid for the disabled working, Medicaid for the blind, Medicaid for individuals on SSI, and then individuals who are receiving room and board. The maximum benefit amounts that the state can pay, we can pay $1,200, we reimburse $1,200 to the funeral home, $1,200 for a funeral, and then $800 for cemetery. The rates were last updated in 2013, and previously the rates were $600 and $400. So from this quarter, we have, year-to-date, we have done 832 reimbursements for cemetery services, and then 4,171 reimbursements for mortuary or funeral expenses.
So the year-to-date expenses for burials is $5.7 million. We're forecasting for the remainder of the year 1.9, giving a total forecast of expenditures 7.6. Our total funding available is 6.2, so we're showing roughly around a 1.3 shortfall in the program. Unfortunately, this has been a challenge for DFR in previous years as well. The program just has been short of funding compared to what the actual services are coming in. So we're planning on finding the funds and carry forward dollars to cover this. Next is our county admin program. Our year-to-date expenditures is $240 million. Our forecasted expenditures.
Can you hold up and just explain what county admin is?
I knew you were going to ask that. So the county admin budget covers everything that touches all three programs. That's the easiest way I think I can describe it. It touches all three programs, so SNAP, TANF, and Medicaid. We do surveying of the staff through random moment sampling to figure out the breakdown, and Kevin, you can jump in and correct me if I'm wrong, to figure out the breakdown of how we allocate across all those programs to federal and state dollars. And this covers the bulk of our staffing costs. A lot of our technology costs are in our facility costs are in this budget.
This is the mechanism by which you fund eligibility determination?
Yes.
Okay, so going back to the fiscal side, so the forecasted expenditures for the remainder of the year is $79 million. Our total forecast expenditures is $319 million. Our total funding available is $296 million. So as of right now, we're showing a shortfall in the program of $23.4 million. And some of that has to do with some things that were outside of our control. On our salary and benefits, there was the GSA adjustment that occurred that wasn't planned in the biennium budget. Then we had some IoT changes that we were required to change in our phone system that wasn't accounted for in our biennium budget. That was $7 million. And then the other main portion, the $11.6 million, was due to some amendments that we had to do, though, from prior to last year and then also for current year that we didn't account for, though. So we're showing a shortfall as of right now of $9 million in state, which, as Sunshine was saying, that we draw down federal funds with the state funds. So without that $9 million, we would be $14.3 million short in federal. So we're covering the $9 million that is short in order to draw down the federal dollars from carry forward funds.
This is the DFR admin summary, and the things that fall under DFR admin are the things that we use to manage the overall administration of the entire division.
So looking at the year-to-date expenditures for, it's 3.7 million. The forecasted expenditures for the remaining of the year is 1.1. The total forecast expenditures is 4.8, and then the funding available is 4.5. We're showing a shortfall of 298,000, and the main driver of that is due to some of the IoT costs that increased and that we weren't anticipating to be as much. And we plan on covering that shortfall with carry forward funds.
This next slide is the IAD summary. The IAD system is the system that DFR uses to determine eligibility. So this is used by all the caseworkers across the state to do SNAP, TANF, and Medicaid eligibility. And this is the specific budget in regards to that.
Looking at the year-to-date expenditures is 26.9 million. The forecasted expenditures for the remainder of the year is 10.6. The total forecasted expenditures is 37.6, and then our funding available is 32.9 million. So we're showing a shortfall in the program of 4.7 million. One of the main drivers of that, if you look at the contracts, the 2.2, we had an amendment that occurred prior to the biennium budget for a Deloitte contract for an increase in enhancements that wasn't accounted for, and then that 3.3 million is due to our postage and our printing is higher than we anticipated, which we plan on covering that 1.6 million in state with carry forward funds in order to draw down the additional 3 million in federal dollars. And the next slide, we're just capturing some of DFR's major contracts. If you look in the third column, it's the total contract value. Then the next column is the annual contract for the state fiscal year. And then we're showing the state and the federal funding for that. And then the year-to-date expenses for the contract for the year. And then the current balance of the contract.
This is a DFR staffing summary. We have the average number of state employees in the third quarter was 1,270, and then the average number of contract employees that we have at DFR is 2,073. And it stayed pretty consistent through this fiscal year. Thank you.
Thank you, Sunshine and team. Marcus, do you want to see if we have anybody has questions?
If anyone wrote questions on note cards, if you could just hold them up, I can pick them up for you. If we don't have questions, then we can efficiently move on. All right.
You, we'll be back at 9:30, and this is part of the process of getting us back on the straight and narrow. Today we'll be discussing, momentarily we'll be discussing the regrettably named Uwe Castle. For those of you who don't know what Uwe Castle means, it is the portion of the agency that funds child care development and a couple of other things. We'll be focusing on the 2025 operations, not on the 2026 budget. And I am appreciative that we will have questions at the end. We have on the screen, we have the Ask the Secretary at fssa.in.gov. And so if you have questions, please feel free to ask them. Marcus Barlow will then take them and read them off. Also, I think we have cards around the room for you as well. So with that, Adam, if you'd like to come out with your team, we'll get on with the meat of the program.
Thank you, Mitch. My name is Adam Alson. I am the Director of the Office of Early Childhood and Out-of-School Learning. And this is my Deputy Director and our Chief of Staff, Sue McKinney. So a little bit of information about me since I'm new to state government here. I took this job on 2 months ago. Prior to that, I was a farmer. But I also have extensive background in the child care space. Was a co-founder and past president of a nonprofit in Rensselaer, Indiana that created affordable and quality child care in Rensselaer, and see the value and the opportunity that child care can do for kids, families, communities, and all of Indiana.
In addition to that, he spent about 10 years on Wall Street as a bond trader.
Prior to me being a farmer in Rensselaer, yes, I worked for Bank of America and worked on Wall Street as a bond trader. Thank you, Mitch. Yes. So as Mitch stated, we are here to talk about the Office of Early Childhood and Out-of-School Learning and the financial statements and financial analysis for Q3 of state fiscal year 2025. Let's start off with what the office does, right? The Office of Early Childhood and Out-of-School Learning has two primary responsibilities. The first is to regulate and license child care programs throughout the state of Indiana. So these come through, these are child care centers, these are registered ministries, these are child care homes, and then they're also legally exempt child care providers. Think of schools. The second thing that we do is we also administer all child care related funds for the state of Indiana. The main thing that we administer is the Child Care Development Fund, which you'll see throughout this presentation is abbreviated as CCDF. We also administer state appropriated funds and then also other federal government grants as directed. The vast majority of what we use these funds for are to fund CCDF vouchers for kids and their families ages 0 to 13, and then also On My Way pre-K voucher program for the state of Indiana for 4-year-olds. So the mission of the office is to effectively support children, families, and providers within Indiana's child care system. And our vision is to maximize the availability of quality child care and child care resources for Hoosier children, families, providers, community stakeholders, and Indiana's workforce. So before we get into the financial side of this, wanted to touch very briefly on some of the major initiatives that the office has had ongoing and we will continue to focus on. First one is voucher wait list and the management of such. As most are aware, there was a wait list for child care vouchers in Indiana that was initiated in 2024. The state budget set state funding levels through 2027 last week. And federal funding for the program continues to be, for next year, is unknown, specifically the Child Care Development Block Grant discretionary funding at the federal level. Our goal as an office is to manage our funding to ensure reauthorization of families currently receiving CCDF vouchers. Something that's a little bit more optimistic is our microfacility pilot program. This was a program initiated by the state legislature in last year's session. And the goal of this program is to increase accessibility and capacity in leveraging existing operational expertise of child care providers through reducing operational costs. And the hope is with these pilots, is to say, is this a viable model to pursue from a regulatory perspective in Indiana? We had 73 applicants and 6 were selected. This process happened earlier this year. Of the 6 that were selected, we got an update from these numbers. There are 5 microfacility pilots that have been opened in the state by the end of April, and there's an additional site that we estimate will open within the next 6 weeks. These are in the counties of Vigo, Marion, Lake, Kosciuszko, St. Joe, and LaPorte counties. We're very excited to see what comes of this. I think there's a lot of opportunity as an office and promise around the microfacility pilot model. Third major initiative is regulatory reform. The office has been re-engaging with external stakeholders over the past few months to reach common goals of reducing regulatory burdens while maintaining health and safety of children. This work is ongoing. We project and target a late 2025 initiation of the rule promulgation process to amend Indiana Administrative Code. So, taking a broad view of of money coming in, money going out of OE-COSL. So, OE-COSL has blended funding stream, just like most parts of FSSA. From the there's federal funding, and then there's also state funding. On the federal side, there's two main sources of funding. The first one is the aforementioned Child Care Development Fund. And then the second one is the state of Indiana transfers annually roughly $62 million from the Temporary Assistance for Needy Families, or TANF program, transferred it to OE-COSL to spend on low-income child care vouchers. Then on the state budget side, there's historically been two line items for the state of Indiana, for OE-COSL from the state of Indiana. The first one is the Early Childhood Learning line, and then the second one is the Pre-K Education line. The third one here, which is in this year's budget, which I know we're not supposed to talk about, Mitch, is something will be new for the next fiscal year. So a preview for 6 months from now, the CCDF Hold Harmless Funding line. That starts in state fiscal year 2026. Very briefly, touching on the metric side of things, because these are important. This is the main thing we're focusing on as an office, is making sure, tracking what our wait list is for vouchers, what's the demand, what can we do. Total vouchers, which are both CCDF vouchers and On My Way vouchers as of the end of March of 2025, is 64,172. And our total wait list as of that date was 13,701. The percent of families that are receiving vouchers that are employed is 94%, and the percentage of families receiving vouchers that are in single-parent households are 88%. Another metric that is of interest in the space is the percentage of vouchers by federal poverty level. Two-thirds of our vouchers, the households of two-thirds of our vouchers, their family incomes are less than 100% of the federal poverty level. And on our wait list, that percentage increases to 93%. Here's a little bit more granular detail about voucher metrics and information about the wait list. The max amount of total vouchers in the state of Indiana was in December. That is Q2 state fiscal year 2025. Between CCDF and On My Way of 69,326. As of the end of March, you can see the decline of outstanding vouchers to 64,172. And you can see how the wait list has increased over the last 6 months. The last part of that table down there, reauthorization. CCDF vouchers reauthorize every 53 weeks. And from a management of this program's perspective, tracking what that reauthorization percentage is very important to make sure that we do not get in a position as we have been recently.
Adam, are we taking anybody off the wait list?
Not at this time. And it is to be determined on when we will begin to, start enrolling new kids for CCDF vouchers. So here's a different way of looking at at our vouchers and historical data. I think the main thing to take away here is that we continue to see increased demand for CCDF vouchers even as the wait list has been put in place. Total total demand, which we can think of it as enrollment plus wait list. In December, if you add those two numbers up, it's around 72,000. As of the end of March, that number increases to 77,800, which is a 7%, it's a 7.6% increase in total voucher demand since we initiated the wait list. So, on to the financial summary. This is our financial summary. As preface here, I wanted to make something, just give a little bit of information, because this is something that 2 months ago when I started, I did not fully understand completely, and it may help. State fiscal years go from 7/1 of the previous year to 6/30 of this current year. So state fiscal year 25 is July 1st of 24 to 6/30 of 25. And then I will also be mentioning federal fiscal year as well, which is a little bit different. That goes from 10/1 of the previous year to 9/30 of the current year. So federal fiscal year 25 is October 1st of 2024 to 9/30 of 2025. It's something that people had to tell me like over and over again the first 2 weeks I was here, so just, I think that may be helpful. Okay. What we have in this slide, and you'll see the same sort of format as we break out each of the individual programs, we've got current month expenditures of the current month, our year-to-date expenditures for the total fiscal year up to the end of Q3, forecasted expenditures for the remainder of the year, then our total forecasted expenditures for the year, the funding available, and our forecasted fund balances at the end of the year. So we're going to go into the program side in more detail in following slides, but these are our main programs, right? And you can see from a very broad perspective, the CCDF program is the program that we use to fund our vouchers. The second most important one and largest that we have here under our watch is the On My Way Pre-K program. From a CCDF perspective, right, our total forecasted expenditures for the year is $530 million. For the On My Way Pre-K program, it's $62 million. So our total, and then the other programs we have is our Head Start. There's a small amount of funding that we're allocated to for Head Start that helps coordinate things between the Head Start programs in Indiana and our office. SAC is the school-age child care line item in the state budget. Last year it was around $812,000. That money goes to after-school programs for a once-a-year grant program that we administer. And then we have child care licensing. That is where fines and fees go for various licensing infractions. And then the other one at the bottom is the preschool development grant. That is a grant that we entered into in 2022 with the federal government. All funds will be spent by that fund by 9/30. Some of the initiatives that we've undertaken in the time is we've undertaken initiatives with the Department of Education, Department of Workforce Development, to strengthen the early childhood workforce in Indiana. We also use seed fund. We also use a small amount of those funds as seed funding for the microfacility pilot program that's ongoing here. The last thing I want to just point out here is down at the bottom portion here, under our total forecasted expenditures and looking at our funding from the breakdown between federal and state. Most of our funding comes from the federal government and from federal funding streams. For this fiscal year, we project, right, our total funding available is $610 million from federal sources. For state sources, it's $92 million, and our total forecasted expenditures are $702 million. 84% of our funding comes from federal sources. So this is looking at our funding in a slightly different way. We're instead of looking at it by program and then by total expenditures over the year, this is a breakout of all of our various funding streams, right, and our various funding sources, whether they be state or federal. And and then breaking those out by each of our expense categories as well. I think this is helpful to see where at the end of the day, it's where we fund, our money goes to vouchers, right? So where does the money come from, and where does it go? So the first three columns are different subfunds within the Child Care Development Fund. The largest one is, and the one that has the most optionality at the federal level to change year to year based on appropriations, is the CCF discretionary, which is the third one there. The next one is the last of the COVID dollars that went out to child care. Those funds were spent by 9/30 of 2024. The next one after that, ARA supplemental discretionary, $5.8 million was additional funding the state of Indiana received from the continuing resolution passed earlier this year in Washington. Then we get into our next two, our two main line items in the state budget: early childhood learning and pre-K education. The early childhood learning funds, most of those funds go to, and most of those funds go to CCDF vouchers. The pre-K education funds, those voucher payments go to fund On My Way vouchers. And then we have a PDG. There's a state match for the PDG match. And then the last one is all of our smaller funds summarized into one. What we as an office do is each of these funds have various restrictions, dependent on the funding source, legislative, requirements. What we do as an office is that our goal is, and we do this, and I've been very impressed about the sophistication that this office has around managing funding, that we strategically allocate costs to various funding sources, and that's twofold. One is to maximize federal funding for childcare in Indiana, but then also to maximize the dollars available for vouchers. There's a couple going over to the total forecasted funding for the year. I'd like to point out that of the $614 million of our total forecasted, total expenses, $495 million have gone out to vouchers. And secondly, then, we go farther down, contracts and grants are the second one, kind of combined. Those are the next two base buckets. And then we have a very small amount from a salary and benefits perspective.
So Adam?
Yes.
Can you flip back to the previous slide? Mm-hmm. Thank you. And this is, you may not know the answer to this question. Paul may know the answer to it. So the previous fiscal year in this biennium, the agency spent the federal COVID money down. This fiscal year, we took TANF Black Grant savings and injected $130 million, if I recall correctly.
That is correct.
Into the program. Where does that show up on this?
It is coming in a future slide.
Oh, great. I'm sorry to steal your thunder.
It's okay. So when this is a pie graph of showing graphically the vast majority of our money goes to vouchers. We want it that way. Have a small amount of overhead. So Mitch, I think this one will answer your question once we get there. This is a breakdown of our child care development. So the next few slides, we're going to break down each of the various funds and programs that we have in a little bit more granular detail. This is the Child Care Development Fund. I will reiterate that this is where the money goes for CCDF vouchers, or comes out of total vouchers. Let's see, total amount of our fund, total amount, let's see. Our total forecast expenditures for the year for this fund is $530 million. Of that, it's $440 million have gone out to vouchers. The rest of it goes to contracts, and then our salaries and benefits and our admin gets paid from this fund as well. As Mitch mentioned a couple minutes ago, there was a one-time transfer of TANF working families monies, $133 million, that was transferred late last year. it was transferred because state of Indiana put too many kids on vouchers, and there was not funding available to do so. This was a stopgap measure in order to get us to a point where we could, where we're at a point where we are continuing to be able to reauthorize children that currently receive CCDF vouchers. Let's go down to the bottom part. I think just to reiterate a point I've made in an additional slide. $611 million worth of funding is the total funding available for this. 93% of it is federal funding. I will note, and it says it on here, but I guess I want to note it as well. Could you go back to the last slide, Sue? That $133 million is not a part of the rest of the report here. It's separate from the numbers that are in the report. Okay, On My Way. So this is On My Way is the program for 4-year-olds and to promote pre-K education in Indiana. In this state fiscal year, we used a blend of state and federal funds to fund On My Way pre-K. In total, we expect roughly $62 million to go out, the vast majority in this fund, the vast majority for voucher payments. 58 million of that 62. A little bit different on this fund is down at the bottom of the sources of funding. This fund is 65% state funded, so the majority of the funding comes from the state rather than coming from the CCDF fund, which is predominantly federal funding. So this is breaking out our contracts line. These are our 9 largest contracts that OE CASEL has. I will briefly go through them. First, let's go through what this slide says. Contractor, that's that's the name of the contractor, obviously. Contract period is when the contract started and when it's projected to end currently. Total contract value is the total value of the contract over the life of the contract. Annual contract amount is the amount is for this year. And then we break that out by state funding and then also federal funding. Year-to-date expenditures is what we've paid out year-to-date on those contracts, and then the current balance on those. So our largest contract that we have is we grouped our eligibility office contracts together into one. They provide intake services throughout the state of Indiana for vouchers, for both for CCDF and On My Way. Our second largest contract is Deloitte. That is a technology project we are undertaking at currently. It's a large-scale system overhaul for on both the licensing and the subsidy side of the office. Shine Early Learning, otherwise also known as Spark, in the space in Indiana. They provide technical assistance for providers and for child care providers and also for child care families as well. Indiana EYC is a contract for technical assistance for workforce development in the ECE space. They do Teach Scholarships, which is a scholarship program for early childhood educators to receive either their CDA, associates, bachelor's, all the way up to a master's degree. Our CCR&R contracts provide technical assistance and also provide support to providers at a more localized level throughout the state of Indiana. The consultant consortium, that is for our existing technology system. And resultant-KSM consulting is associated with our large tech project we're undertaking currently. RadCube is our case monitoring and document management systems. And Granicus does communications, external communications for the office. From a staffing perspective, we are currently 80 people internally that are employees of the state of Indiana, and our contractor we help fund 327 full-time equivalent contractor employees as well. And then we will go briefly through some of the other funds very quickly. Our other ones. mentioned preschool development funds a little bit earlier. This just breaks out and shows where those breaks out a little bit farther where those funds go and have gone in the past. The one thing I will note is there was a state match, approximately of 20%, which you see down at the bottom through the sources of funding. That what that is a required state match for this program. I'll reiterate that these funds will be spent by the end of this, will need to be spent by the end of this calendar year. We'll move on very quickly to the school-aged child care or SAC fund. This is state allocated funds, line item in the state budget. Goes to what we use these for, the grant programs, for after-school programs to increase their services and increase and do some really neat things in their places locally. Head Start Fund next. This funds coordination with Head Start programs in Indiana. It's a requirement of the Head Start program. And then Child Care Licensing Fund, you'll see it's a very small amount. This is where all our fees and fines go. That is it. Thank you all for the opportunity here. I think excited to see where the future goes with OE COSL and child care here.
Thank you, Adam. I think, Marcus, we have some time for questions. If you'd orchestrate, please.
Yeah, if anyone has any questions on note cards, please hold them up and I'll grab them. We can start with one question, though. Why is there a wait list if there's a fund balance?
We have to make sure that the main thing that we need to think about, and it's a very good question, the main thing that we as an office we are very concerned about, and our goal is to make sure that first, existing vouchers, right? Kids and families that currently receive vouchers will continue to receive them as long as possible, right? Well, as long as they're statutorily required to do, right? That is our goal, and our goal is to maximize that. The problem is it's not that, it's actually pretty complex to try to determine what future voucher enrollment will be over a period of time. And we would like, what we want to do is we want to make sure that we are being actively managing this, and two, making sure that we also take the wait list off as soon as possible.
This question is from Michelle Height Thomas. With the LEAP district in our backyard, we were disappointed that SB 463 passed without the County Child Care Assistance Fund language. Understanding that we are dealing with a CCDF waitlist and other legislative priorities, how can we work with the state to help us increase the capacity and affordability of child care in our area?
I think that what we can do is first be very good. What we can do is be proactive with local initiatives when they are thinking about getting child care centers and new initiatives off the ground. And that means, obviously we don't have funding available for that, but what we can do is we can be proactive and helpful from a regulatory and licensing perspective. That is one thing that we can do, I think, in maybe slightly different ways than we have in the past.
Mention of engaging to reduce regulatory burdens vis-a-vis licensed child care. Is significant flexibility needed from deregulation in Indiana code compared to other states, or is it more of a rulemaking issue?
I mean, I think that's kind of how you would, I view it first and foremost as something that the administrative code around child care in Indiana has not been refreshed in many, many years. Our priority as an office through the process will be health, is health and safety of kids, right? That's what we're doing here, right? Just making sure that parents are that parents feel good about dropping their kid off at a child care center, right, that we license. From a regulatory perspective and a re-regulation perspective, we want to strike a very good balance, right? We want to take updated, we want to take best practices and put them in here in Indiana, right? From a regulatory perspective. And what the goal is here is to make it more efficient and easier for providers to not, right, to do the thing that they want to do, right, which is to take care of kids. And that's what they do really well anyway.
We have one final question. Can you please describe the intended outcomes of the micro-facility pilot? How will they be measured, and what might indicate that this is a promising practice to the point that the pilot will be expanded?
Well, I think there's a challenge broadly in Indiana around, from a supply perspective. That challenge will probably continue to exist over the next couple of years. The microfacility pilot, from what I've seen from the beginnings of it, is that what we're doing is we're allowing existing child care providers to make the decision around, currently in Indiana, a lot of child care providers, if you're going to start a new center, if you have an existing center, you're going to start another center, it is a massive undertaking, right, from the perspective of that operator. What we want to do, and what I think our goal is to say, hey, is there a different regulatory auspice that allows you to not say, okay, you've got a center that has 200 kids. It's not doubling your capacity. It's saying, hey, can you do it piecemeal and say, maybe I found an appropriate building, or a building in a place where I can add additional 20 kids, 30 kids to my broader operation. Currently, from a regulatory perspective, that's very hard to do. What we'll be looking for is right, we are going, and our team has done a great job in getting this off the ground. I've went up to Gary earlier this week and saw what one of these were. It's the exact sort of thing that we're supposed to be doing, I think, and I think there's opportunity there. It's an existing childcare. That one about Gary, the one in Gary, the existing childcare center is in Hammond, and there's an opportunity in Gary to purchase and renovate a building, a very small building, to increase capacity in a place where there is no childcare. Right? This is to help. This is to help rural areas. This is to help. This is to help neighborhoods in our cities and in our suburbs to right-size childcare supply throughout the state. What we hope to see out of these pilots is does our regulatory framework work? What's the P&L on these things look like? What are the challenges from an operational perspective? And are there things that we can do better as we think about potentially rolling this out more broadly throughout the state? To be clear, there's a whole bunch of other steps that need to happen before we do that. This pilot program, I think, will get us a lot of information to help make those decisions in a much more informed way, as both an office and a state.
And Adam, when you stood up your child care in Rensselaer, you lived through all those experiences, not with a very rickety regulatory process.
Yes. I mean, there's, I know it personally. I know it inherently that there are, and it's, and I also understand the balance. I also understand what we're trying to do at the end of the day, right? We want good quality childcare seats, right? And good places for people to go and kids to go. And it's making sure that we're striking that balance in a very conscious and very intentional way.
Well, thank you very much for being here. Thank you, Adam. Thank you, and team. Thank you very much for your work today, and safe travels back to Rensselaer.
Thank you, Mitch.
Thank you. Good morning, everyone. It's good to see you all. Thanks for being here in person and online. We're pleased for the opportunity to provide the quarterly financial update information for the Division of Disability and Rehabilitative Services. I'm Kathy Robinson. I'm the Associate Director for the division. As Mitch mentioned, Kelly is not here today, but she is here in spirit. I have with me Christina Commons, the Director of the Bureau of Child Development Services, Teresa Colazar, the Director of the Bureau of Rehabilitation Services, and Holly Wimsat, the Director of the Bureau of Disability Services. So we're going to, at the top of our presentation, I'll be covering a division-wide financial summary, and the Bureau directors will cover their respective program information, and then we'll wrap up with some division updates and current contract information. So hopefully that flow works for everyone. I want to just take a minute to share how our division is administratively organized. So we do have three distinct bureaus. Together, they operate with over 500 full-time staff across the state. The Bureau of Disability Services supports services for individuals with physical and/or intellectual disabilities across their lifespan to live independently as possible in their communities. This could look like assistance in accessing their Medicaid waiver services, group home living, or coordination of other community supports. The Bureau of Rehabilitation Services assists job seekers with their paths to employment, as well as programs to support independence and local community access options. And then finally, the Bureau of Child Development Services administers First Steps, and this program supports infants and toddlers who have developmental delays up to their third birthday through therapies and other services, and offers education and strategies to families to assist them in meeting their child's developmental needs. So I'll start here with DDRS financial summary information. This table provides an overview of the DDRS financial summary and a breakdown of the Bureau's specific expenditures, including our forecasted fund balances. Within this overall summary, I will note that there's a mix of administration funds and service funds. The DDRS admin budget was the first line that you'll see on the table. That budget is really relatively small. With these funds, we are supporting 7 state staff salaries, administrative supplies, indirect costs. We do have a projected forecast balance for these funds, the 217,633. We are just noting here that those are often used as state dollars to leverage other match funds, so there is some flexibility there in our budget to do that, so we ultimately intend to use potential available balance there for that purpose. For the Bureau of Child Development Services, you'll note there's a roughly $5.7 million projected fund balance there. I'm going to let Christina speak a little bit more to that in her Bureau presentation in terms of how that projected balance is forecast and kind of how those dollars ultimately end up getting used. And then with the Bureau of Rehabilitation Services, there is also a small forecasted balance projected. These are associated with the contracts line of the BRS budget. Teresa will also speak to that in her portion, but it is also anticipated that those funds will be utilized. At the bottom is a breakdown of our full-time employee summary information, where you can see how the staff summary looks across the division. We have total of 490 filled positions at this time in terms of state staff, and then we do have some temp contractor resources at 9.9 FTE. Looking at this slide, it reflects a pie chart of the previous slide's forecasted expenditures. So you can see here the proportion of expenditures by program allocation. The green is the Bureau of Rehab Services, the orange is the Bureau of Child Development Services, the dark blue is our division's administration dollars, and the magenta is the Turnstone appropriation. I want to note these are non-Medicaid forecast expenditures, as the slide says. So Holly will be presenting her Bureau's Medicaid service expenditures later in this presentation, so that's where you will see that information covered. But just wanted to note here the majority of the non-Medicaid forecasted expenditures are in that Bureau of Rehab Services portion. Again, non-Medicaid forecasted funding for DDRS based on allocated state, federal, and dedicated funds. As you can see, the vast majority of our non-Medicaid forecasted funding is federal in nature. That's via the Department of Education and Health and Human Services administered funds. The orange represents the current state budget appropriation. The small green portion reflects the amount of dedicated funds we're accessing. You'll see those show up and be reflected in the financial summary for BRS when Teresa covers that portion. And the green is again, that dedicated funding, which I already just spoke to. So now I'm going to turn it over to Christina Commons with First Steps so that she can cover her program-specific information.
Wonderful. Good morning, everyone. As Kathy mentioned, I'm Christina Commons, and I have the absolute privilege of being our director of our Bureau of Child Development Services, which oversees our First Steps program. First Steps is Indiana's early intervention program, annually serving roughly 30,000 children with developmental delays or disabilities aged birth to 3 and their families, and we serve them in all 92 counties of Indiana. We have 8 state staff located in our central office. We contract with 4 entities to run 9 local regional offices called Systems Points of Entry. And we hold agreements with 43 provider agencies statewide, as well as 100 independent providers. Last fiscal year, Indiana provided First Step services to about 2% of Indiana's children aged birth to 1, and 6.2% of children birth to 3. First Steps is a coordinated system working to ensure infants, toddlers, and their families are supported timely and effectively so children meet their developmental milestones and outcomes. Systems Points of Entry work to identify all potentially eligible children in their local regions. They take referrals, determine program eligibility, and provide service coordination. Agencies and independent providers deliver critical individualized family service plan, or IFSP, services and supports. And the data system is a comprehensive electronic record of each child and their services. Billing and claiming ensures providers are paid timely for their services rendered, and the professional development program and program evaluation contractors ensure all personnel are trained, are using best practices, and all policies and procedures are followed. While not a comprehensive list of all of the services provided by First Steps, this list does outline those most commonly used by children and families that are written on their individualized family service plans. Historically, speech therapy has been the highest utilized service, and many children have more than one service written on their IFSP to help them achieve their outcomes and developmental milestones. Indiana First Steps utilizes a central finance system. We pay providers fee for service and operate a pay and chase model. The graphic here is how the state pays and recoups the cost paid for services rendered to children and their families. And this is how FSSA supports and sustains the program. In our recent federal monitoring visit in August of 2024, Indiana's system of payments received high praise and was being recognized as a model for other states. FSSA braids and blends a variety of funding sources to implement the First Steps program, which includes private insurance. In 2019, we identified opportunities to improve insurance recoupment, which included better claims processing practices. And since 2022, First Steps has increased its recoupment by over $10 million, creating sustainability even with an increase in the number of children served and hours of services provided. First Steps is an entitlement program, providing services and supports to children and families regardless of income. As I mentioned, the success in fund recovery has helped us support the growth in the program, and on any given day, there are roughly 13,000 children and families with active IFSPs. When children turn 3, they are no longer eligible to receive First Steps, and we work collaboratively with our Department of Education to support families through their children's transition to the public school system so they can receive early childhood special education services. And to date, in state fiscal year 25, roughly 4,800 children have transitioned to receive services through their local public school districts, and over 2,300 children have met their service plan outcomes before the age of 3. As you can see here, the majority of First Steps funding is spent on contracts and services. As I mentioned in previous slides, service claims are paid with state dollars, and then due to our pay and chase model, it takes roughly a full 3 months before fully processing all of those claims through the various funding streams and sources before it's fully known which source will actually pay for that child's service. Monies flow in and out of state funding balance week over week. Thus, the forecasted balance is an estimate based on the payment status on March 31st and is likely to be reduced at the end of the 3-month pay and chase cycle for the state fiscal year. We anticipate that balance to be quite a bit lower. So with that, I'll turn it over to Teresa.
Just before you get started, if I may, thank you very much. And as you know, my first time I was in the saddle, First Steps was a tremendous area of focus, and the team has done so much to improve the outcome of the program, the pay and chase portion, the geographic distribution. So literally, my hat is off to you.
All right, good morning. I'm Teresa Colzar with the Bureau of Rehabilitation Services. You received a little glimpse of the main functions of the 4 Bureau of Rehab Services, or BRS units, earlier in the presentation, so I'll go quickly here. Vocational rehabilitation is the Bureau's largest unit, serving eligible individuals with all types of disabilities to obtain employment. We carry out most functions in-house through BRS staff, and that is mostly through field staff. They perform intake and eligibility, service planning and authorization, case management functions, counseling and guidance, et cetera. We also purchase several services from vendors and providers, and we'll look at that briefly today. Other units in the Bureau include blind and visual impairment services, supporting business opportunities for blind Hoosiers, deaf and hard of hearing services. They certify state interpreters and promote communication access. And then we also serve as the state liaison agency for the Indiana Independent Living Network. I'm going to cover a few things on our metrics slide here. The VR program has experienced significant growth over the last few years, about a 30% increase in applicants just since state fiscal year 22. And the number of applicants we've had this state fiscal year through March has already exceeded the total applicants that we received in the last completed state fiscal year. I want to note on the figure here that you see on open active cases, this is really only a partial representation of the folks the entire Bureau serves. This does not include students with disabilities that are served through a service structure called Pre-Employment Transition Services, or PREETS. That is a 15% federal set-aside or earmark, and that is approximately another 9,000 or so individuals. So in total, just between the VR enrolled individuals and those students who are receiving PREETS, we are really serving about 25,000 active cases in the VR program each year. And then additionally, those other programs we mentioned, blind and deaf services, independent living, they serve additional Hoosiers with disabilities. I also will briefly touch on outcomes here. Again, back to VR, the goal is to obtain employment, and we are seeing an upward trend there, about an 8% improvement this past quarter. Again, the number you see here, the 1384, is really representative of just those who've obtained employment who've already exited the VR system. That is the goal of the VR program, is that folks are on their way after they are successfully working. However, we also have individuals who are currently active in the system who are working and just have not completed all their services, or they're still maybe receiving a few supports to be as successful as they can in that job. So in total, that's around 2,000 individuals who have been working since the beginning of this state fiscal year. We also have a state plan goal of a 25% increase in employment outcomes by the end of the next state fiscal year, and we are on track to reach that. We actually just surpassed our state fiscal year 24 exits with employment, and again, still have a quarter to go. Two more items briefly. Some of you are aware that we were able to reduce VR wait list to 0 this past October, and we are remaining without a wait list as of today. And then finally, I want to calculate or touch on the calculated or aggregate annual earnings. Again, the goal of vocational rehabilitation is employment, and we are able to capture median quarterly wages for folks 4 quarters after they exit. So this is simply a calculation of the number of individuals who were retaining employment 4 quarters after exit times those median wages and annualized, and those earnings represent almost $24 million. The data that you see here comes from our most recently completed comprehensive statewide needs assessment. That is an assessment we are federally required to complete every 3 years. So this covers 3 years of folks served over, again, that 3-year period. During that time, and really still fairly representative of where we are today, about 79% of eligible individuals in VR were those with the most significant disabilities and the greatest barriers to employment. In terms of the type of disability, over 36% of those had a primary impairment of an intellectual or developmental disability, followed by about 30% with a mental health diagnosis, 21% some type of physical disability, and then 13% who were deaf, hard of hearing, blind or visually impaired, or deaf-blind. When looking at both primary and secondary, you may notice that the most common type of impairment or condition experienced by VR participants is a mental health condition. VR provides a very wide menu of services. Hopefully you can see some of those service categories here. And again, the goal here of every service is that it helps someone move toward that employment outcome. So the slide here breaks down those client service expenses by category. The long line there, the wide line there is employment services. That is for VR participants of any working age. And then the second largest category are those pre-employment transition services, or PREETs, those services for students. Those two categories combined account for about half of client service expenses. Training accounts for about 13% of client service expenses, and then rehabilitation technology, including assistive technology devices, training on using those devices, and also inclusive of home and vehicle modifications, accounts for about another 13%. And then the remaining 25% of client service expenses are on a range of services. A few examples: low vision services, brain injury services, transportation-related, medical-related, and supporting participants with self-employment opportunities. I'm just going to touch on the pie chart here. You can see the other detail as you like in the blue boxes. The Bureau of Rehab Services is heavily federally funded. About 76% of our funds are federal. State funds account for 21%, and nearly all of those are leveraged as match. Our grants are typically either a 90-10 or roughly 80-20 match ratio. And then, as Kathy mentioned earlier, we do generate some revenue. About 3% of our budget comes from revenue generated through both vocational rehabilitation and blind services. And finally, lots of numbers here on budgets. Almost 80% of our budget is direct service related, and that includes a combination of these different categories. Not everything fits cleanly into, one line. So that includes a combination of some staffing. The largest chunk of our staffing are field-based direct services staff. We call them VR counselors. They are, again, those frontline service-oriented staff. They're performing intake and eligibility, as mentioned, service authorization and planning, case management, and then vocational counseling and guidance. Also, the social service line is fully direct services. Over half of our contracts are service-oriented. That is where those pre-ETS services to students fall. And then finally, the grants here largely represent some pass-through dollars to independent living and services to those who are older individuals who are blind, as well as to deaf Hoosiers. I also want to touch really quickly, Kathy mentioned just under a $42,000 forecast balance that was showing up here as of March 31. We have actually already redistributed that to leverage that as match to support the ability to draw down some additional VR dollars. Again, the largest fund source is federal, and this is broken out here to distinguish current federal
Pardon me, on the
grant
VR,
funds.
on the VR, I think, on the VR question.
Yes.
Do we fully pull down all of the match available for us?
We do not. That's a great question. We do not currently pull down all of the federal match available to us. We use all of our state allocations to do that, and then we are generating some additional match, but there is still additional federal dollars allocated. On that note, the breakout here of federal funds by current grant year, and that's our federal fiscal year, and carryover year, is important. We have this trend of very high carryover during 2020, 2021, and we've been very thankful, actually, for that higher than normal carryover because it timed really well with this growth in services that we're seeing. However, we are anticipating that high carryover has ended. It is quickly coming to an end, and we'll be back to more of a baseline budget. So we will be actively implementing strategies to streamline, to spread available resources as we try to best position the program for that growth.
All right. Thank you, Teresa. I'm Holly Wimsatt with the Bureau of Disability Services. So just starting out with a little bit of an introduction, the Bureau of Disability Services has 8 field offices located throughout the state. We administer 4 home and community-based or waiver services, Medicaid waiver services, and we license provider-owned and operated supervised group living settings throughout the state as well. Additionally, we enroll providers and monitor provider service provision. The map that you see is just a demonstration of participants served by county in Indiana. So as I just mentioned, the Bureau operates 4 home and community-based services waivers. The Family Supports Waiver, we support over 24,000 individuals with intellectual and developmental disabilities. The Community Integration and Habilitation Waiver, we support over 9,000 individuals with intellectual and developmental disabilities on this waiver. The Health and Wellness Waiver, we support 13,600 roughly individuals who would otherwise also qualify for nursing facility placement on the Health and Wellness Waiver, and those are individuals under 60 years of age. The Traumatic Brain Injury Waiver is our smallest waiver. At the end of March, we were supporting 180 individuals who have experienced a traumatic brain injury.
Holly, are any of these waivers currently in managed care?
They are not. That's a great question. These are all fee-for-service waivers. Thank you. So our supervised group living, or often referred to as group home with the Bureau, are residential settings for adults with intellectual and developmental disabilities. The Bureau currently supports 2,600 eligible individuals in 414 supervised group living settings across the state. Again, these are residential settings that are owned and operated by licensed providers. We have seen over time a decrease in the number of supervised group living settings. In 2023, we had 447 supervised group livings, and as of the end of March, we were at 414. The average annual cost this state fiscal year to date for an individual in a supervised group living setting is almost $124,000 a year. Our home and community-based waiver program metrics, the average authorized waiver budget per individual supported through the community integration, excuse me, community integration habilitation waiver for state fiscal year to date, just as with the supervised group living, is around $131,000 a year per person. The health and wellness waiver, the average authorized budget for someone under 60 years of age on the health and wellness waiver is roughly $69,000 per year. And then our traumatic brain injury waiver, again, a very small waiver in terms of number. The average authorized budget for an individual on the traumatic brain injury waiver is about $94,000 per year. The family support waiver is not captured here because it is a capped waiver. So on the bottom part of your screen, you see mention of something called invitations. This is the term we use when we are inviting individuals off of one of our home and community-based services waiver waiting lists. The number of invitations we are able to issue when we issue them is dependent on the number of slots in our waivers, which is also fiscally driven. State fiscal year to date, we have invited state fiscal year to date, we have invited over 3,000 individuals to the health and wellness waiver and over 2,000 individuals to the family supports waiver. Reflected on this screen is our family support waiver and our health and wellness waiver. Again, these are the two waivers that we currently have waiting lists for. As you will see, the family supports waiver, there has been steady growth in the number of participants on that waiver, as well as growth in the number of people being supported through the health and wellness waiver. There has also been growth on the waiting lists for those waivers, and I'll talk in a moment about the family support waiver wait list. But the important thing to note here is while we are serving more people and there are more people on the wait list, we are serving more people on these waivers than we have in the past. The top of the screen here is referencing the number of applications for BEADS, the Bureau of Disability Services, specifically for individuals with intellectual and developmental disabilities. We have seen over 150% increase in the number of applications we have received for services since 2020. In February of 2021, the Bureau rolled out an online application for services, which is when we saw our largest spike in applications, but we have maintained averaging 600 applications per month for BEAD services for individuals with intellectual and developmental disabilities. Much as Teresa mentioned with the VR field offices, the Bureau of Disability Services has state staff in those district offices I mentioned earlier. We have 34 and a half full-time equivalents, or 34 full-time equivalents and one half-time equivalent that support the work of intake and eligibility determinations for those individuals with intellectual and developmental disabilities. So those 600 applications a month are handled by 34 full-time equivalents. During for state fiscal year to date, we have made over 32,000 eligibility determinations for individuals with intellectual and developmental disabilities. Additionally, during that same time period, we have seen over 53,000 eligibility determinations for individuals seeking supports through the health and wellness, the traumatic brain injury waiver, and the pathways waiver. So this is the BEADS Medicaid expenditures pie chart. I'm not going to spend too much time here, but I want to note, you will see in the dark blue, the community integration and habilitation waiver accounts for 39% of the Bureau's Medicaid expenditures while serving 9,000 people. The health and wellness waiver accounts for 26% of the Bureau's Medicaid expenditures while supporting over 13,000 people. When you look at the supervised group living or small group home, as it's displayed here on this screen, that accounts for about 12% of the BEADS Medicaid expenditures while supporting 2,600 people. And then we have the family supports waiver, 13% of BEADS Medicaid expenditures supporting over 24,000 people. The small group home or supervised group living is an institutional setting. And again, we're spending about 12% of our Medicaid expenditures in that realm. The family support waiver with the 13%, those are services that support people in their own homes and in their communities. These are a listing of the BEADS expenses. I want to note the social service payments on the line with the forecasted fund balance. Those are funds utilized for non-waiver services, specifically supported employment follow-along, which is a service provided for individuals who are working, often having been through the vocational rehabilitation program, and also services for individuals with intellectual and developmental disabilities who are in long-term nursing facility care. The forecasted fund balance, those funds are also used for state match to draw down federal dollars to use for Medicaid administrative expenses as well. We do not, or we do anticipate utilizing all of those funds for the state match. And then you can see the breakdown of the federal and state funding within the Bureau with no dedicated funds in the Bureau of.
Holly, let me, if I may, there are Medicaid dollars on this slide, and as there well should be. There will also be, when we get to OMPP later in the afternoon, we will look at these dollars a different way. But I just wanted the audience to understand that if they're trying to make this foot, right, it's nearly impossible to make it foot. So don't try. Even Paul can't make it foot. So I wanted to point that out. Thank you.
No, thank you. Thank you. Yes, there is a definite intersection. Most of BEAD services are funded through Medicaid. So thank you for clarifying that.
Oh, yep, sorry.
Oh, okay. No, you're good. So again, most of our services are Medicaid funded, and a lot of this information will be covered when the Office of Medicaid Policy and Planning speak, much like Secretary Rowe just noted. So I do want to talk a little bit about the large private facility very quickly. There is one of those in the state. It is 20 bed. It serves individuals, adults with intellectual and developmental disabilities with the most significant needs and very complex needs with co-occurring mental health needs. The age and disabled waiver, again, you will see some of this a little later when the OMPP is sitting in these chairs. The age and disabled waiver no longer, or was retired on June 30th of 2024. Individuals that were on that waiver on July 1st transitioned to our Pathways for Aging waiver, and under 60 transitioned to the health and wellness waiver. So as you look later in this chart on the health and wellness waiver, you'll see there is a blank cell there. That's because the health and wellness waiver did not exist in its current state until July 1st of 2024. The community integration and habilitation waiver, you'll see is showing some expenditures there. We have seen an increase in cost for our residential habilitation and support, both hourly and daily, and are exploring that difference that we've seen recently, where the hourly rate is being utilized more than the daily rate. We have also seen, that isn't visible here, an increase in cost related to behavior support and rec therapy as well, specifically on the community integration and habilitation waiver. All right, thank you. Kathy?
Thanks, everybody. I'm just going to wrap up on these final few slides to just speak to the overall DDRS admin program summary. This is a callback from the earlier slides where we talked about the DDRS administration budget. Really, this is where you see the 217,633 in forecasted fund balance and where that falls in the overall budget. That is $72,000 in salary and benefits. That is a result of our division utilizing some of the American Rescue Plan Act funds to support salary for a team member, and that is why there's a fund balance there, but we anticipate that to, given those funds are no longer available, that will revert back to utilizing it for that salaried position. And then we have some contract dollars remaining, and that's anticipated to also be fully spent down. Those are a variety of things captured there. You'll see memberships or subscription type expenses there for the program. This is a summary of the DRS contracts. This is not all of our contracts, but it is a good number of them. I just want to note on this, we have consolidated some of the contract information for the purposes of the summary. Christina mentioned earlier the systems points of entry. There are 4 vendors who are doing that throughout the state, so this total contract value and annual contract amount is for all combined for all 4 of those entities performing those functions, as well as Teresa mentioned earlier, the pre-employment transition services, and there are 13 of those, and those have been combined into this line item to reflect the total contract value for all of those. Liberty of Indiana, that vendor does the incident reporting and monitoring for our waiver systems across the fee-for-service landscape that Holly just talked about. There are a couple of public consulting group contracts. One, I believe the first one is for First Steps, and the work that they're doing on the fund recovery that Christina spoke about. And then the second is the BRS contract for PCG for the IT functions that they perform there. So a lot of different contracts for us. I think one of the points I'll make here is that we rely on these vendors to support a lot of our program administration and operations, which allows us to really maintain staff levels at a pretty manageable level for ongoing kind of sustainability for the division. But that's the biggest piece there is takeaway is how much these vendors are kind of supporting our ongoing operational functioning. So I'll just spend a minute here to talk about some DDRS major initiatives and to spare you all. I will not read them all point by point, but just want to note many of you, I see a lot of familiar faces in the audience, so many of you probably know about or have heard about a number of these initiatives. They've been things that the division has been undertaking. We are always working to try to maintain, enhance, or improve our systems of services and supports, so we really just felt it important to highlight or acknowledge some of these efforts. This again also allows us or affords us the opportunity at times to engage in some modernization and improvement initiatives because we have some other vendor support who are doing those day-to-day functions. Again, I think Not to go through all of them, I just would note that the overarching objectives across these initiatives, there's a common theme, and it's really to help us continue to realize efficiencies and build some sustainable models of service and supports for people with disabilities. I will note the VR systems consolidation and documentation streamlining was a recent initiative, and I think has a lot of promise in terms of helping boots on the ground do their work more efficiently. We have the bead system consolidation work, which is quite a heavy lift, but again, works us toward consolidating systems into one or two IT systems, ideally. Been working on that for quite some time. And then, just noting the First Steps data quality work that Christina and her team have also been heavily engaged in with PCG and other vendors to try to ensure that they have a good handle on not only their program metrics, but how they're doing with the fund recovery piece, which is a huge portion of their sustainability. So that's really it for DDRS. I've appreciated the time this morning, and we'll take a minute and pause and see if there's any questions.
Yes, we have one question from Jason McManus. Can you please explain why Indiana is not drawing down all of the available federal match? What would we need to be in place in order to do so?
Teresa, that sounds like
So
a question
I
for
think
you.
that sounds like a VR question. So the federal VR grant has continued to increase year over year, whereas the allocated state dollars have remained fairly flat. I mentioned we are able to generate some non-federal match to help pull down those federal dollars, and we're doing that. We're increasing that each year. But there is still some available dollars beyond what we are pulling. Now, when we do return dollars, we've been able to get some of that back. So for example, we applied for successfully and were able to obtain a Disability Innovation Fund grant a couple years ago. That was from return dollars, and we were able to get that back through that special grant without a match. The return funds are then redistributed across other VR programs around the states, around the nation, rather.
And I do shed a tear every time we leave $1 on the table.
We do.
Holly?
Yes.
Marcus, can I ask a question?
Yes, of course.
Can you go back to the previous slide? Okay, can you spend just a moment on where we are with level of care modernization?
Yes, I can. So we are in the process with our nursing facility level of care, which is, again, utilized for access to the health and wellness waiver, the pathways waiver, and for some individuals, the traumatic brain injury waiver. So we have been looking at how we have been assessing level of care in that realm, and identifying ways that we can more appropriately assess individuals, particularly youth, who are seeking services and supports through those waivers. So we will be launching some new tools. The level of care itself has not changed, the level of care requirements, but we'll be implementing some tools for youth on July 1st that will better assess children and will better ensure that as part of that assessment, we have a better idea of those children's needs so that we can support those individuals and families in seeking services to support them from a more holistic approach and not just what's available, through the waiver. So, does that answer your question? Great question. All right.
We just got a few more questions on note cards. And I want to apologize ahead of time if I misread your handwriting. It's been a long time since I've seen cursive. Regarding First Steps, does the cost of collecting the cost participation fee from families cover the amount of dollars received?
Right. I think what is being asked is are we upside down on our cost benefit analysis and what we recoup through family fees versus the cost to administer that. I've not done a CBA in some time on this, in this area, but I think we have reduced the administrative cost of implementing family fees. Through our online parent portal, we have options for parents to go green, which has decreased our postage cost. Even though the cost of postage has increased, we have fewer families being mailed their statements directly. They're able to access their statements in real time, and they're able to make online payments using their HSA accounts or credit cards, et cetera, to make virtual payments. And then we've done a lot of training with our systems point of entry to better understand how to collect income information. A few years ago, through the legislature, we were able to decrease administrative burden in collecting income from families who are also participating in other programs such as CCDF, WIC, et cetera, and Medicaid, because they're already collecting income information. And so we've been trying to decrease the administrative burden of administrating family fees.
Is the state still actively working to transition group homes to waiver homes?
I can take that one. I think that one was meant for the Bureau of Disability Services. So certainly providers have the option to request conversion of a supervised group living home to waivers. So there is not a plan to mandate that. Certainly what we want to do is make sure that individuals in those settings have a choice of remaining in a supervised group living setting or choosing home and community-based services.
Final question from Christina. Are any steps being taken to ensure accuracy, given the reoccurring issues with EI Hub in the current accounting reporting process for First Steps?
I don't know if I understand the question. Can you repeat it?
Are any steps being taken to ensure accuracy, given the reoccurring issues with the EI Hub in the current accounting reporting process for First Steps?
I'm not quite sure if that was your question, if you feel comfortable rephrasing it maybe for me. But we have been working diligently with Public Consulting Group on system remediation to ensure all of our contract deliverables and requirements are met and in the system. We participated in over probably 40 hours of meetings with PCG to revise and talk about the gaps that we found in that system and identify ways that we could improve it. Right now, we are finding fewer and fewer data gaps when we're pulling data. We do have a data analyst dedicated to our team who is working to pull data and is working directly with our systems point of entry and their data entry staff to ensure comprehensive data validity. And so I think we're fairly confident that what we've presented today is accurate.
Okay, thanks very much. We've got 7 minutes till the Division of Aging asks the questions once we're done. So again, thank you for being here, and I'd like to ask the Division of Aging team to come out and begin their presentation.
Good morning, everyone. Want to welcome you to the Division of Aging's quarterly financial review presentation. My name is Steve Gale. I am the controller for the Division of Aging.
My name is Vanessa Convard. I'm the Service Enrichment and Advancement Director.
And I am Erin Wright. I am the Director of Access and Engagement with the Division of Aging. It's nice to see so many of you here and those of you joining us online. Thank you. So the Division of Aging serves Hoosiers by facilitating access and supports so individuals may age in a dignified manner of their choosing. This is supported through a number of programs listed here on the screen that we will be reviewing both programmatically and financially with you this morning.
This first slide is an overview of the entire Division of Aging's financial status. It shows on the very first column to the left a list of all of our main programs, of which there are 12, followed by the current monthly expenditures, the year-to-date expenditures, and what we forecast for the remainder of the state fiscal year through June 30th, as well as the total funded forecasted expenditures, the total funding available, and finally, what we forecast will be the balance as of June 30th. And I want to point out a couple of things from this slide, the first being that 60% of our total funding comes from federal sources, a variety of different federal grants that we receive from the Administration of Community Living. But we also receive, of course, some state funding too, mostly from the general fund appropriations, but also some from the Tobacco Master Settlement Fund, which is a dedicated source of funding. And I want to point out the forecasted fund balance of $26 million. A sizable portion of that comes from our Title III program. And when we get to the Title III program slide, I will explain in more detail why there is such a large amount, or what appears to be at least a large amount of funds that will be carried over after June 30th. This slide shows a pie chart that kind of breaks down three main areas in which our funding supports. 63% of all of our funding goes to our area agencies on aging, or what we just commonly refer to as our AAAs. They receive most of that money in the form of some kind of a grant. And there are a couple of contracts in which they also receive money too. We have 16 of these area agencies on aging throughout the state, and most of that funding then is in the form of both federal dollars and state dollars. We also have another 29% of our funds which go to other entities in the form of contracts. And some of those also are federal dollars as well as state dollars. And then the remaining 8% is what is used for state administration of our program, which includes things like staff, some IT-related costs, other supporting costs for the staff, travel, things of that nature. And that's what we utilize to be able to operate our central office here in Indianapolis.
The Division of Aging is designated as Indiana's state unit on aging under the Federal Older Americans Act. And within this role, the division designated local organizations as area agencies on aging, or AAAs, as Steve was just discussing, to address the needs and concerns of older adults and caregivers in their assigned counties. And the map shows the 16 different service areas across the state. The AAAs are involved in some way in the majority of the programs that we're going to talk about today. And as Steve said, they receive over 60% of the Division of Aging's funding through grants and contracts. Most of the direct services that are available through these awards are delivered through local service providers. Services that are core to the AAA designation, such as care management, information and assistance, and outreach, are provided directly by the AAAs.
This gets into more detail about the funding that goes to our AAAs. As you can see, it comes from a variety of different program sources, which includes our Adult Guardianship Services Program, the American Rescue Plan Act, choice, dementia care, and others. The three largest sources of funding that goes to the AAAs comes from the Title III program, which is a federal-funded program. It comes also from Choice, which is our largest share of state appropriation we receive. Of all the state dollars that we do receive, almost 75% of it comes from the Choice program. And then also the American Rescue Plan Act supplies a sizable portion of dollars that went to the AAAs also, which those particular grants expire as of September 30th. About 61% of the total funding that goes to the AAAs comes from the federal grants, which is consistent with the division's overall level of funding.
Title III funds a variety of home and community-based services for both older adults and caregivers. And when combined with social services block grant funding that is awarded to the AAAs, in the month of February, over 10,000 individuals were served, and that's the most recent month we have complete data for. We have highlighted here some of the top services for last year. For example, nearly 260,000 one-way transportation trips were provided, and this includes trips to everything from the doctor, the grocery store, or a senior center. Over 55,000 hours of respite care were provided to family caregivers, providing a much-needed break from caregiving activities. Through Title III, the AAAs address elder justice through contracts with legal service providers. Last federal fiscal year 24, 4,569 unique individuals received legal services through Title III. These individuals received over 13,000 hours of legal services for an investment of only a little over $255,000. The effective rate is $19.34 per hour. The average private practice value of these services is $250 per hour, which leads to these legal services that would have cost $3.3 million. The legal services provided address basic needs, and these are described here: housing, financial powers of attorney, healthcare powers of attorney, and debt challenges were the top issues the legal service providers addressed last year. And these are issues that are nearly impossible to tackle without some sort of legal help. As a result of the limited nature of this grant funding, there are waiting lists to access services through Title III and the other DA-funded home and community-based services programs. And the bar chart reflects the waiting list through March by individual program and illustrates the growth that we've seen since the beginning of this state fiscal year.
Now we're going to take a look at the financial report for the Title III program. Again, that is a federal-funded program through the Older Americans Act. Most of these dollars do make their way to the AAAs, and I'll explain in a moment further about some of the funding issues we have there. But I wanted to point out that normally we get somewhere around $28 to $29 million a year from the Title III federal grants that we receive. But you'll notice that in the funding available column, it shows $46 million. There's good reasons for that. When the pandemic started in 2020, we began, like so many other government agencies, to receive several different COVID-related federal grants. And as those grants came in, most of that money was also disseminated to the AAAs. So the AAAs have had a challenge of trying to spend down all of their dollars that they received from the COVID-related grants, while at first having to put aside expenditure of their regular Title III dollars. So we found ourselves in a position where now the AAAs are still trying to spend down their American Rescue Plan Act money, while at the same time also trying to spend down regular Title III money. And the Administration for Community Living gave us no-cost extensions of both our Federal 23 and Federal 24 grants, so many of the AAAs are still spending down those prior year funds and also trying to catch up now on what they have for federal fiscal year 25. That is the main reason why we have a $12 million forecasted funding balance as of June 30th, as the AAAs basically are trying to play catch-up at this point, trying to spend down some of the federal dollars that they have received. So they're going to continue to work on that, and I'm sure that on the next quarterly report, we're going to probably reflect a much different view of where things stand as far as the forecasted balance is concerned.
The CHOICE program supports a range of home and community-based services to older adults and individuals under the age of 60 with a disability. This quarter, over 1,600 individuals received CHOICE-funded services. So CHOICE is a 100% state-funded program that delays or prevents the need for more costly long-term care. On average, last year, the CHOICE program cost the state about $5,200 per person annually, compared to the state portion of the cost of nursing facility care, which exceeded $28,000 annually. It serves as a way to divert individuals away from Medicaid or more costly Medicaid-funded services. CHOICE supports individuals' abilities to remain in their home, addresses functional needs of daily living sooner, and helps to maintain independence. And as shown earlier, and it's reiterated here, there are currently over 3,000 individuals on the waiting list for CHOICE.
So when we went through, earlier this year, when we went through the painful experience of discerning what we were spending those dollars on, I was, and I think everybody who looked at that, with the exception of you, was surprised to see that how little we were spending on home modifications and how much we were spending on attendant care in that space. So for those who have not seen that list, we're happy, that document, we provided to several members of the legislature. We're happy to provide it to anybody who else wants to look at the individual services that are provided here.
And the individuals receiving attendant care through CHOICE, as CHOICE is the funding of last resort, are not eligible for attendant care services through another CHOICE at the time, another program at the time that they're receiving services. But we are looking at ways to increase the number of those shorter term interventions like home modifications, handy chore, et cetera.
And now we will look at the CHOICE financial report. This particular funding that we receive is from the state's general fund, at least the bulk of it is, and $29.3 million of that goes to the AAAs. So again, this is another source of funding that largely ends up in the hands of the AAAs through our state grants. But we also have some money that goes towards paying for the CAMS system, or a case management system. That is also supported by CHOICE, but also supported with Medicaid dollars too. So we do have Medicaid federal funds that support the CHOICE program, largely through the payment for the maintenance and operation and any enhancements that occur for the CAMS system. And we also have other contracts too, such as rowing and some other smaller ones. But this is mainly state funds and federal Medicaid funds, and we're continuing to spend those
Just
down.
let me be clear, rowing is a consulting firm, not an activity.
True. Correct, yes. Yes.
The Aging and Disability Resource Centers, or ADRCs, are a primary door to access long-term services and supports. And the ADRCs are housed within the Area Agencies on Aging, and they provide information and assistance, eligibility determination and assessment, options counseling, and Medicaid application assistance to connect individuals with available resources. And so far this state fiscal year, they have provided over 160,000 information and assistance contacts and received over 33,000 waiver intake referrals. And as shown here, the ADRCs are supported through many different federal, state, and even local funding streams. And this reflects really the many different resources and avenues that the ADRCs help individuals to navigate. And as we transition level of care assessments to a new vendor beginning July 1st, the ADRCs, as really the no wrong door entity, will continue to play a crucial role in helping individuals navigate the oftentimes complex long-term care system more effectively and efficiently.
Okay, so it says each of the 15 AAAs are designated. We have, just to make sure that I got this right, we have 16 AAAs. Two of the AAAs are run by one organization.
Yes.
Okay.
Yes, so sometimes we say 15 AAAs serving 16 areas, sometimes it's, yeah.
Want the public to know that we have not collapsed one of the AAAs.
Yes, no.
Yet.
Yeah, I believe I misspoke earlier. I think I said 16 AAAs, but yeah, my apologies.
Yeah.
Now we're going to take a look at the Social Services Block Grant, or what's also just commonly known as SSBG. This is all federal dollars, and we receive these dollars from the Department of Child Services, and that is through a memorandum of understanding, or an MOU. We receive $9 million each year from DCS for these dollars. All but about 500,000 ends up going to the AAAs. Sorry, I probably sound like a broken record, but a lot of these funding sources do help to fund the AAAs for providing the direct services that they provide. We are on track, I think, to spend the bulk of this money. I fully anticipate that the forecasted fund balance of $1.8 million you see as the AAAs continue to play catch-up is probably going to be reduced by the time we get to the next quarterly reports.
Sorry to keep asking questions of you guys, but is there a reason why we get the money from DCS and then we give the money to the AAAs? Why don't the AAAs just contract directly with DCS?
It's an excellent question. The SSBG dollars help to pay for the different types of services that are provided through our program. So I think we just do the memorandum of understanding with them to get those dollars that we can then pass on to the AAAs. So it becomes part of the overall pot of money that they use to fund the services, the direct services for the elderly people.
And we submit essentially a proposal or a spend plan to DCS, which then they in turn compile all of the plans they receive from state agencies and submit those as a package to the federal HHS office that administers the program, which is ACF, Administration of Children and Families.
So last year, Indiana's long-term care ombudsman program served close to 60,000 residents. With only 20 local ombudsmen, we investigated nearly 1,600 complaints, attended 192 resident council meetings, provided over 5,100 instances of information and assistance, and participated in 479 facility surveys. The graph here highlights the reach, how many facilities were visited, how often, how many received routine access visits, the visits in each quarter of the reporting year that are not tied to a complaint. These visits are a performance metric for the ombudsman. The top complaints for nursing homes involved resident care, a lack of autonomy, and discharges or evictions. Top complaints for residents of assisted living facilities involve discharges / evictions as well, resident care, and concerns with abuse, neglect, and exploitation. And I'm going to read a quote for you that we have from a resident's granddaughter about the long-term care ombudsman program. She stated, "If it weren't for the ombudsman's intervention and the ombudsman program, I truly might have missed out on an opportunity to tell my grandma how much I love her and to keep showing her honor. Please know that the unique service provided by people like the ombudsman is priceless to people in my situation."
take a look at the financial status for the Long-Term Care Ombudsman Program. About 73% of the overall funding from this program also ends up with our AAAs. We get funding mainly from the Older Americans Act Title VII program, but we also have 2 American Rescue Plan Act grants that are helping to fund this program. And then there's a small portion of state dollars that we also receive. 73%, as I said, goes to the AAAs. The remainder of it does go to the state office for different purposes, such as administrative and operating expenses, and a couple of folks they have on contract.
Over the next couple of slides, we're going to talk about our dementia strategic plan and our dementia care outreach program. So the strategic plan to address dementia was established during the 2021 legislative session in House Bill 1177. The strategic plan is supported by the Alzheimer's Association of Greater Indiana, SACOA, Dementia Friends Indiana, the Division of Aging, the Indiana Association for Home and Hospice Care, Indiana University, and the University of Southern Indiana, all of whom come together for that plan. The purpose is to identify and reduce the prevalence of dementia in Indiana. I'm not going to read the statistics for you word for word, but these do show you why this is so important. Like, what is the purpose of this program? Indiana really needs to focus more efforts on serving people who are living with dementia right now and their caregivers because the population is growing and a multi-sector effort is needed to ensure that we create a network of support. The plan, the Dementia Strategic Plan, encompasses several initiatives, including the Dementia Care Specialist Program. The Dementia Care Specialist Program was established through House Bill 1422. The program is a collaboration between the Division of Aging and the area agencies on aging and is part, of course, of the Dementia Strategic Plan. There are 18 dementia outreach specialists across the state that are out of the 15 or 16 AAAs across the state. The purpose of this program is to expand dementia-capable care and services and increase public awareness. The target audience here is, again, people who are living with dementia, their caregivers, the AAA staff, community organizations, and healthcare providers. The 3 pillars of this program are professional development, community engagement, and community coordination. The DOSs, as we call them, our dementia outreach specialists, are growing their professional development and applying that knowledge to the target audience. While they do not work directly with people who are living with dementia, they work closely with all of the agencies that do. So a really good example of that right now is that we have one DOS who is training police departments in their area to have healthy interactions with people who are living with dementia and better understand how to de-escalate situations and potentially save lives. The total budget for this collaboration with the AAAs and for the DOSs is $79,687. This goes to salaries, training programs, and resources.
This is our first program that we're looking at in which it is 100% state funded. We receive an annual appropriation for this. And again, the bulk of it ends up going to the AAAs. As Vanessa stated, they receive each one of them receives about $79,000, or $1.275 million of our annual appropriation ends up to the AAAs. The remainder of it supports one full-time staff member and the supporting costs that support that staff member.
I'm going to switch gears and talk about our nutrition programs. Through the AAAs, we support nutrition services with the goal to provide high-quality, person-centered services that promote health and well-being by addressing food insecurity, hunger, and malnutrition, while also enhancing socialization opportunities. We have a dietitian on our team that provides expertise, technical assistance, and monitoring of these programs. So far this year, over 1.4 million nutritionally balanced meals have been served. And as the pie chart shows, the majority of the funding, nearly 3/4, comes from the Federal Older Americans Act. Home-delivered meals, often commonly referred to as Meals on Wheels, provide nutritionally balanced meals to individuals at home while providing access to nutrition education, nutritional screening, and for those receiving a daily hot meal, a regular well-being check-in. The primary participant of the home-delivered meal program, Lives Alone, has been identified as being high nutrition risk and needs assistance with instrumental activities of daily living, things such as cooking, cleaning, and shopping, which are key to being independent. So this program provides an intervention that reaches people in need and positively impacts health, which in turn can lessen the need for more costly supports and care down the road. The Congregate Nutrition Program provides nutritionally balanced meals while also providing an opportunity for socialization, nutrition education, and screening for food insecurity and malnutrition risks. There are over 226 active Congregate Nutrition sites across the state. And these are located in senior centers, senior housing, libraries, and places of worship. Plus, there are also voucher programs, which typically are in restaurants or even hospital cafeterias. On average this year, these sites have provided over 50,000 meals per month. And the map shows the distribution of these sites around the state, and the size of the dot indicates the average number of meals served per month. So the majority of the congregate meal attendees are low-income females who live alone, and the program offers an important way for them to remain connected to others and supporting social and nutritional well-being.
This program, unlike the previous one, is totally funded with federal dollars. It's 100% federally funded. All of the dollars from this program goes to the AAAs. And the AAAs, similar to Title III and similar to SSBG, they are continuing to play catch-up on spending these dollars too. And again, though, I fully anticipate we're going to end up spending most of these dollars by the time we get to June 30th.
The Division of Aging also has a small adult guardianship services program. The Adult Guardianship Services Program provides legal protection to adults who cannot make decisions due to incapacity. The purpose of the program is to protect the adult's well-being and rights while supporting their independence when feasible. In Q3, we had 122 individuals who were served through this program. The total spent during this quarter was $98,891. with an average cost per case of $2,368. These numbers tend to remain the same on average over the year.
This program is fully funded by state general fund dollars, and as you probably noticed on the previous slide, if you don't mind going back to that real quick, thank you. In the bottom left, the chart that has the green bars shows the 4 entities through which we contract to be able to provide these services. 3 of them are AAAs, and the 4th one is a private entity that's the Mental Health of America in Allen County. Pretty much we spend all these dollars every single year. I see no reason to anticipate we won't again this year.
Money Follows the Person is a federal grant program designed to help the state move individuals from institutional settings to home and community-based settings. So far this year, 250 people have transitioned from an institutional to one of the waivers listed here. We are on a temporary pause of new enrollments into MFP. As of April, there were 355 individuals remaining in Money Follows the Person. 120 individuals in MFP CIH, 45 in MFP H&W, and 190 in MFP Pathways. We are awaiting federal approval of the year's MFP budget to determine our ability to resume enrollments, which would be our intent. We expect to hear back on this budget from CMS in the next couple of weeks. We would need to ensure MFP enrollment stay within the approved waiver slot counts, so this would be part of our slot tracking process when we resume.
Okay, so this is a pretty complex thing to dovetail into our waiver wait list and these, to figure out when we're going to take people off of that list and put them into the waiver. And we don't have to get into that today, but could you just spend a couple minutes explaining the financials around MFP in terms of how that operates?
I will defer to Steve on that.
Okay. You want to go ahead and turn to the next slide? This may deal with some of that. We receive the vast majority of the money from this through the CMS, the Centers for Medicaid Studies and so on, through the federal government. Most of that money ends up going to support the cost of folks transitioning from nursing facilities into home and community-based settings. In fact, that pretty much accounts for 99% of all of our funding and the expenditures. That happens, people who end up qualifying for this program end up going through a 12-month period of transition in which the MFP funding covers those costs of the services that they are provided. And those also are funded by state match money that we receive through Medicaid.
The federal match is higher on this program.
That is correct.
Right, okay.
Yes. In fact, the current match is close to 85%, whereas I believe on the regular waiver, it's more like 66 or 67%.
You're correct.
So this is our Adult Protective Services Program. This aims to investigate reports of potential harm to endangered adults. In Q3, we had 3,263 cases across the state. The total spent for Q3 was $1,289,011 with an average cost per case of $395. Currently, this program is run in partnership with the prosecutors' hubs across the state and has been since it began in the early 80s. But as of Wednesday, the state announced that we will be under a new contract with PCG Indiana, which is a subsidiary of Public Consulting Group, as of July 1st, 2025. Over the next 2 months, we will work with PCG Indiana as well as the current APS units to establish an APS model for Indiana that aligns better with our new federal requirements as well as best practice recommendations.
Do you articulate why it is we had 15 different areas?
For Adult Protective Services,
Yeah.
why there's so many, yeah. Because when it was first started, they decided that the best way to go about it would be to partner with the prosecutor's offices and therefore have the units out of each of the hubs. At the time, we had very little guidance on what an Adult Protective Services program should look like. We just knew that we had to do one. So all the states were given, a requirement from the federal government for the first time to have some kind of Adult Protective Services program. But there wasn't a lot of research yet to really understand what that should look like. So every state just did the best they could with what their resources were. And slowly over time, we have all adjusted and modernized and updated. And since then, the National Adult Protective Services Association was formed, and some research has been done around best practice to truly understand what the program should look like. And so now we are transitioning into something much closer to our best practice recommendations.
So you can correct me if I misspeak, but my understanding is we had 16 at one point. Now we have 8A, 8, and 8B, which again is 16,
Yes.
which is a recurring theme here. Is it 15 or 16? It's a recurring theme.
Yeah,
But
can
my
tell.
understanding is that that was originally structured because there were 16 state police posts.
Oh, yes, you know what, I think you're right, yes, yeah, that is correct. And yeah, you can tell from the way the numbers are that this obviously has changed over time.
Yeah.
It's not how our numbers looked when we started.
This is the the only program in which we receive funding through a dedicated fund. We receive annually almost $5.5 million that comes through the Tobacco Master Settlement Fund. But this program is also supported with federal Medicaid dollars as well. This program does support 2 full-time staff. There are 2 people also on contract, and that's as a result of the APS ARPA grant, the American Rescue Plan Act grant, that they still have until the end of September. And there's also now a continuing program from the federal government through the Elder Justice Act, or what we refer to as the Elder Justice Act grants. And those are helping to support both people that we have on contract. Some of these dollars also support the supporting costs of the 2 full-time staff, but most of it goes to, until this transition, through the different county prosecutors who've taken on the task of overseeing this program and conducting investigations and providing emergency services. That will probably, well, not probably, but will continue through the end of June, and once we have been able to process their final claims. So we're in that transition period now, which means that it will look a little differently in future years.
Residential Care Assistance Program, or RCAP, is a state-funded program designed to support eligible low-income individuals who reside in licensed residential care facilities. And 70 to 75% of the residents on this program have experienced some form of mental health disorder, ranging from bipolar conditions to severe depression. And the map reflects the areas of the state that have RCAP providers. Currently, Indiana has 14 licensed room and board assistance providers and 7 county home providers. So in recent months, the RCAP program has experienced a noticeable decline in enrollment. And this trend is largely attributed to updates in Medicaid income eligibility guidelines, as well as the annual cost of living adjustments applied to Social Security benefits, which have impacted eligibility. The graph shows the number of residents from July 24 to March of 2025, and this quarter there have been 2 new enrollments and 38 discharges from the program. The total RCAP funding shows a decrease in state dollars spent largely due to the decline in membership. Total funding per person in the RCAP program represents the full amount of financial support allocated to cover the cost of care and services for each eligible resident. So this includes the daily per diem rate, as well as additional funds required to meet the individual needs, such as personal care, supervision, and basic living expenses within the residential care setting. The data in the pie chart highlights the significant variations in funding distribution among the providers, with one receiving the highest allocation, and the facility has 100% of its residents enrolled in the program.
As Aaron just pointed out, there's been a decrease in enrollment. We've been seeing decreases happening specifically ever since the public health emergency. We've seen a corresponding decrease in expenditures for this program as well. So you may note that the expense category that we call provider per diem reimbursement, which is the amount that we are reimbursing the different providers for their costs, you'll see that there is a forecasted fund balance on that specific line of $3.2 million. That is a reflection of the decrease or the decline in enrollment that we've seen in this program. It is 100% state funded, and we'll hopefully be taking measures to be able to spend more of those dollars in the future. The Special Projects Financial Summary. These are some of our smaller programs. They include things like the ALS appropriation that we had received. It's a $1 million appropriation that we contract out to the ALS Association. It also includes some expenditures we had early on in this state fiscal year for the No Wrong Door Governance Grant. That grant has ended. It ended, I believe it was the end of August. Is that correct, Aaron?
Yes.
Okay. And also includes 2 federal grants we received for the purpose of expanding the public health workforce. And both of those grants will be coming to an end at the end of September as well. And our Division of Aging admin summary, this really has three different sources of administrative funds. There is our main aging admin program, which is about a $750,000 appropriation. But this also includes a state appropriation we receive for what is called the Division of Aging Services. And then we also include in here our Medicaid waiver administration program as well. And most of the expenditures that are included in this particular report includes staff, which we do have staff on the administrative program, but we also are carrying some vacancies I will address in a moment. And we also include staff with our Medicaid waiver admin program and also the ADRC contracts that are paid or helped funded through that. Speaking of the vacancies, you'll see at the bottom of this chart that we currently in the Division of Aging have 22 positions that are filled with full-time staff, but we also are carrying 8 vacancies, which we are working on addressing that as well. And then our slide here shows our summary of our major contracts. You'll see right at the top of it, the top 3 are all AAA contracts. We've broken out in about 5 or 6 years ago, we broke out what used to be one large grant that we would give to the AAAs that had both federal and state dollars. And we split that out into 2 separate grants that each one receives. One is dominated by federal dollars. That's where our Title III, Title VII, SSBG, and INSIP programs are located. And then the state program includes choice, and also the assisted living appropriation we receive for the ombudsman program. The ARPA dollars are also shown here in this report, which are due to expire at the end of September. But it also includes our Adult Protective Services program, the ADRC contracts with the AAAs, the Dementia Care Program contracts with the AAAs, and the ALS Association contract.
So here we have our list of other major initiatives. We won't be going into detail over these today. Perhaps at a future QFR we will. But see, these are some of the other projects and programs that we are currently working on developing, or are ongoing and are forever being developed. Thank you so much. Do we have any questions? Yeah, sounds like it. Sounds like everyone wants lunch. That's,
Okay. Thank you very much.
Thank you.
Saddle again. Thank you all for being here. Several of you have endured this more than once. In fact, several of you endured this the last time we did it, which was too long ago. So welcome to the first quarterly financial review of the Braun administration. Governor Braun asked that I start these again. Candidly, I would have anyway, because of the transparency and accountability it brings. 2 things that I think the agency had lost its, about which the agency had lost its way, and of course the fiscal responsibility is critical to our state's success. The success of the providers, the success of the recipients, and giving the members of the General Assembly an ability to budget correctly. So this afternoon, we're starting with the Office of Medicaid Policy and Planning, and you can see on my hat is their job description. And as you probably know, it reads, "Make Medicaid boring again." And we are working to do that. So this discussion today is going to be about the 2005 budget and the work they have done to make more Medicaid boring again in 2005. It is not about 2025. I apologize. I do live in the past sometimes. 2025. We are not discussing 2026 today. We'll do that at a future time. If you have questions during the presentation, write them down on a note card or email them to the address on the screen, and we will collect these questions, and Marcus will ask them. So with that, Lindsay et al., could you please come out?
Hi, good afternoon, everyone. My name is Lindsay Lux. I'm the Deputy and the Chief of Staff for Indiana Medicaid. Joining me on stage is Leslie Melton, our Controller, and Kathy Leonard, who is our Director of Reimbursement and Actuarial Services. Kathy is actually going to kick off the presentation today, going through the Medicaid assistance budget.
Thank you, Lindsay. So, in terms of our presentation on Medicaid assistance, we're going to start with just a brief summary of the overall results. We're going to switch over and go into enrollment, and then we are going to compare expenditures to forecasts at different, based on different levels. We have a few watch areas that we've identified that we want to share with the group of things that we're looking at in terms of the emerging results. And then I will be turning it over to Leslie Melton to discuss some of the funding and the program PMPMs, and Lindsay to talk about the contracts. So in terms of the highest level results and what we're going to be talking today, I want to make sure that everyone understands the results that we're looking at. These are year-to-date results through March for the current fiscal year, so it represents 9 months worth of data. The next time that we meet, we'll be looking at comparisons to the forecast that just was presented in April. But for today, we're going to be comparing the emerging results to what was shown in the December of 2024 forecast. So in terms of enrollment and expenditures, both were slightly under forecast. The enrollment came in 1.6% less than forecast for that 9-month period, and the expenditures came in at 3.2% less than forecast. So we're going to start with discussing enrollment first, because we want to make sure everyone understands where the types of populations that we're covering. And so we've got 2 different slides for enrollment. The first one is for our managed care programs. And we currently have close to 85% of our enrollment covered through one of these 4 managed care programs. You can see in total for managed care, as it shows in the blue box on the side, we were 0.6% under the forecast for enrollment, so very close. And each of the different plans, the Healthy Indiana plan, which covers adults, was slightly under the enrollment forecast. Hoosier Care Connect was slightly over, but our other 2 programs were also a little bit under forecast. So for the most part, managed care did come in under the forecast by about 0.6%. The other group that we have enrollment for is our fee-for-service enrollment. And fee-for-service also came in less than forecast on a year-to-date basis, 6% less than forecast. And you can see again here the various types of coverage, and for the most part, they were under forecast. The top section shows the counts for institutionalized members or waiver members, and then the bottom section shows the members with no levels of care. We had a couple of areas that have a larger than average variance. Our Hoosier Healthwise fee-for-service, retroactivity adjustment, and our limited benefit populations. But again, overall, we are pretty close to the amounts that we were forecasting for the fiscal year. So now we're going to switch to expenditures. We always look at the enrollment first because you usually expect your expenditures to sort of be in the same direction as your enrollment. If your enrollment's a little higher or a little lower, you would expect your expenditures to be moving in the same direction. So if we look at the bottom, sort of the bottom line here, for those 9 months, the forecast was that the expenditures would be $15.6 billion, and the actuals came in lower than that at $15.1 billion. So you see the variance, $491 million across the board in terms of all of the different expenditures. Now, when we do our financial reporting and our forecasting, we usually break expenditures into 4 different categories that you see here. Managed care being the first one, then fee-for-service, and then we have other expenditures and manual expenditures. So if you look at the totals for each of these categories, you'll see each of them are coming in with a positive variance to forecast. The breakdown is pretty consistent across the board. Also wanted to point out managed care, as you would expect, with having most of the members, has the highest number of expenditures, but instead of representing 85% of the spend, it's closer to 75 because some of the managed care members are less costly than other types of members. So what we're going to do next is look at each of those 4 categories and go down to one more level of detail. So if we go to the managed care slide, again, what you see when compared to forecast, each of the 4 programs is showing a positive variance. All of them are coming in with expenditures that were slightly less than what we were forecasting for this fiscal year. So across the board, about a 1.6% variance coming in lower than the forecast amounts. If we switch to fee-for-service, this is a category where, again, you'll see at the top in total, our expenditures are coming in less than forecast. The total is about 1.4%. But what you'll see in the variance column there is we have some areas that are coming in above forecast, and we have others that are coming in lower. So we are coming in better than forecast for institutional care and for waiver services in aggregate, but we do have some waiver areas that are showing as above forecast. And those are some of the ones that we'll be addressing on some of our watch list slides. But we do have a little bit of a mixed bag there, but in aggregate, we still are coming in better than forecast. Our third category, other expenditures and collections. The largest collection that we have in this category that really tends to drive the results is sort of in the middle there, the pharmacy rebates. So what you can see here is for this category, we're showing that we're significantly higher than what was forecast, and the primary driver is the pharmacy rebates. So these are rebates that the state receives from manufacturers for the pharmaceuticals that are administered to our Medicaid members. So that is the main driver of this other expenditure category, positive results. Then our final category is manual expenditures. Again, what we're seeing here is the manual expenditures for the year are 5.2% less than forecast. There are some variances here, some are positive and some are negative. So we have some hospital supplemental payments that are coming in at a different timing that are a positive contributor to forecast, but we have some other supplemental payments and also some payments to our FQHC providers that are coming in above forecast, and those are some areas that we're going to continue to look at. But again, in total, the category is positive to forecast. Yes. Okay. All right, so what we're going to switch to is a few areas that we identified as watch areas. And watch areas can be areas that are running better than expected or worse than expected. We dig down into both of them. This one is our health and wellness waiver. Attendant care expenses are coming in much lower than forecast. So the forecast is shown in the blue bars, and the actuals are showing up in the orange bars. This is one where we believe some of the attendant care decline is due to better management of those services, but we also believe some of it could be that members are accessing care through our home health program. So for future meetings, we're doing some research now to see how we can look at that more holistically. But this is one that was running a little higher than expected. Our next watch area is residential habilitation services under the Community Integration and Habilitation Waiver. For the past 3 months, this one has been showing a little bit higher than forecast, and I think if you were in the DDARS meeting earlier today, we are working with that team on trying to research what is driving that. We think it has to do with a mix of services that are being provided. So this is one we're going to continue to watch. You can see the gap has gotten better in the more recent months, but that is one we're going to continue to watch. And we also had higher than expected for residential habilitation services under our Money Follows a Person program. This one we're looking at, but we think it's more a forecasting issue. We were forecasting for that program to be frozen, and we ended up continuing it. Finally, we have a watch area for our PACE program. This is a program where we're seeing higher than forecasted enrollment. We believe that some of this is due to individuals moving to PACE instead of the Pathways program. So we're going to continue to look at this as well, and we're forecasting some changes for the future. And then the final watch area, and this is a different kind of slide because all of our other slides were showing month by month paid comparisons between actual and forecast. Our final slide is for ABA therapy, and we are just showing these results because this is an area that is getting a lot of focus. So we wanted to share the emerging data. Unlike the other slides, this is on a date of service basis, so it's not based on when the claims were paid, it's based on when they were incurred. And I think that the things we'd want to point out, we're showing 2 lines on here. The green line is managed care, the blue line is fee-for-service. So on the left side, we're seeing the number of fee-for-service recipients flattening out. But the green line is showing that we're continuing to see more and more recipients in our managed care programs. And because we're continuing to see that level of growth in the managed care programs, we also are seeing increases in the expenditures for ABA therapy. Now, I did want to point out on the expenditure chart, you'll see some a decrease in the expenditures. That has to do with seasonality, and then they flatten out a little bit because in January of 2024 is when we had implemented a fee schedule. But all in all, we are still seeing continued expenditures in the managed care program, and that is an area that we are going to continue to watch. All right, so for the funding portion, I am going to turn this over to Leslie.
Good afternoon. As you can see, our shortfall year-to-date is $360 million. That's about $127 million more than what is forecasted. You would expect that with expenditures being lower than forecasted, that our shortfall would have decreased also. However, there are a couple of things that are driving that increase in our projected shortfall year-to-date. Our collections are lower than projected, primarily the hospital assessment fees, and it's a timing issue between when we collect them and when we actually move them into the Med Assistance Fund. We anticipate that we will catch up by year end, and we also are drawing down less federal dollars than projected, and that one of the issues causing that is the increase in the pharmacy rebates. When we collect pharmacy rebates, we have to return the federal share of those rebates back to the federal government. And since they are more than projected year-to-date, it's impacting our federal share. And then there are several smaller things that we haven't.
So this slide is good news, right? So the fact that that we were forecast to have 232 million in total shortfall surplus. We actually have a surplus here of 359 million as of March 2025.
No, these numbers represent actual shortfalls.
Shortfalls.
We will be short in funding at 232 million at year end.
Thank you.
In addition to the hospital assessment fee collections and the federal dollars, we have some smaller transfers that won't occur, or IGTs that won't be transferred until the end of the state fiscal year, which is June. Those are our IGTs from the Department of Education, the Department of Corrections, and we will still need to do the IGTs for our CCBH program. This is our per member per month slide. The per member per month is the average Medicaid cost per individual per month. We're looking at a quarterly view right now. To calculate that per member per month cost, we divide the total expenditures by the enrollment. A couple of PMPMs we want to point out. For the Healthy Indiana Plan Q2, you'll see that that PMPM is less than Q1. The PMPM for the HIP program is typically around $600. In Q2, there were retro rates implemented. Those rates were lower than the rates that were currently in place, which caused a decrease in expenditures. So for Q2, the Healthy Indiana Plan expenditures were decreased to significantly lower than what we typically see. And then for Q3, in January, around January of each year, we usually pay out the power count payments. And so we paid out about $883 million in January in power count payments, which caused that increase in spend, thus increasing our PMPM for that quarter. If you look at the nursing facility Q1 PMPM, that PMPM is significantly higher than the following 2 quarters, and that's due to claims run out. As you know, most of that, or maybe you do know or you don't know, most of that population has moved to the Pathways program, and so the expenditures are for members that have transitioned to the Pathways program. So we're still counting the dollars here, but the members are under Pathways. The same is true for hospice. It's a claims run out issue for that first quarter. For Money Follows the Person, second quarter, you'll see that that PMPM is significantly lower than the other 2 quarters. During October of 2024, approximately 2.7 million in MFP claims were voided due to a level of care update. Those claims were repaid in the new level of care, so which I believe was the health and hospital waiver, and some in the A&D waiver. And for PACE, the Program for All-Inclusive Care of the Elderly, the first quarter, you'll see that that PMPM is also much higher than the following quarters, and that was due to a rate adjustment that was implemented in September of 2024 that increased the expenditures for that month and that quarter. We will be moving into admin next.
Before we get to admin, from our Medicaid assistance bucket, you can see the majority of our managed care contracts are listed here along with the contract value. I will say that these contracts are paid through the fiscal agent, and it is a capitation, a per member per month payment based on the enrollment that they have. All right, we will start with Medicaid administration overview. So the Medicaid administration represents a very small portion of Medicaid spend. It's less than 1%, and we're looking at around $168 million for state fiscal year 25. In general, the costs incurred by the states in administering the Medicaid program are matched by the federal government at a 50-50. However, there are a few pieces that are matched higher in the administration. For example, we receive a 90% federal match for our claims and eligibility system design, development, and implementation. That is not ongoing operations, but for any of that design, development, and implementation work. We also receive 75% federal match for that maintenance and operations, for the electronic visit and verification, for program integrity work on fraud, waste, and abuse, the managed care review activities, which are external quality reviews, pre-admission screening, and skilled medical professionals. The majority of these items require CMS advance approval through their APD or advanced planning document process. Next, I'll go through the components of the Medicaid administration budget. First up is CHIP, or the Children's Health Insurance Plan program, where we operate two benefit packages. Package A, that may be considered more of a traditional Medicaid package, and Package C, which has higher income limits and requires a monthly premium and small co-payments. The federal match for CHIP is 75%. Healthy Indiana Plan program operating costs are separated from Medicaid programs for tracking purposes only. The federal match for HIP admin follows the same as Medicaid admin, which ranges from 50% to 90%. The Indiana Prescription Plan, commonly referred to as Hoosier RX, it is not a Medicaid program in that there is no federal match for the program. It is funded 100% by state dollars through the Tobacco Master Settlement. Currently, this program helps cover the Medicare Part D premium for 156 seniors in need. And then finally, the overall Medicaid administration. So outside of those three programs we just discussed, CHIP, HIP, and Hoosier RX, the remaining administrative operating expenses of Indiana Medicaid fall into this Medicaid administration account, and the federal match here, like HIP, is 50% to 90%. This chart represents state fiscal year 25 expenditures through March. As you can see, the majority of the Medicaid admin spend is in vendor contracts, and that comes in at 90% of the spend. Staff salary and benefits equals 9%, with another 1% in other operating admin costs. The four programs I just reviewed are combined here into one. You can see that salary and benefits are coming in a little under budget. That's due to staff vacancies. The contract spend is coming in less than projected. The average monthly contract spend was projected to be $12.8 million per month. The variance for the year, the variance is driven by a lag in vendor invoicing due to some contract amendments, but also due to a rather sizable reversion of funds here, where we capitalized on using the home and community-based service funds available to us through the American Rescue Plan Act, Section 9817. Due to that, we see this $16 million. It is not actual, so the majority of these funds are federal due to that reversion that we did for those ARPA funds. So these funds are not available to us without additional state funds. The provider application fees are fees that we collect from providers enrolling into Indiana Medicaid. These fees are used to offset other Medicaid administration expenses. Admin and operating are IoT charges, state systems such as PeopleSoft and Human Resources. Our other admin costs are primarily mailings and some minor office equipment. We've been frugal there in spending just due to the change in mailing cost. For funding, year-to-date, state fiscal year 25, we're running 50% federal, 40% state, and 3% dedicated. And those dedicated funds include the cigarette tax and tobacco master settlement funds. This shows the Office of Medicaid Policy and Planning staffing. We run a pretty lean team. We have 140 positions allocated to us, and we are currently at 115 staff members. Next up are our top 10 contracts in Medicaid admin. So this chart represents spend through March of the state fiscal year and the remaining balance of the contract not to exceed amount. Gainwell Technologies is our Medicaid fiscal agent. They pay capitation for us, they pay fee-for-service claims, they manage the member enrollment into Medicaid programs and provider enrollment. The Maximus LCAR contract is the level of care assessment work, which is in implementation by the Division of Disability and Rehabilitative Services. It begins on 7/1 of 25 and is paid for through Medicaid. Optum Government Solutions is our enterprise data warehouse vendor managed by FSSA Data and Analytics. Optum Rx is our fee-for-service pharmacy benefits manager, or PBM. Myers & Stauffer helps set Indiana Medicaid reimbursement rates. The Health and Hospital Corporation contract is support for covering kids and families, and the Health and Hospital Corporation covers the state share of that contract. Keypro is our fee-for-service prior authorization vendor. Milliman performs actuarial services for Indiana Medicaid. Deloitte is the vendor for our fraud abuse detection software and services, or FADS. And Myers & Stauffer has another contract with Medicaid to perform audits on long-term care cost reporting. Finally, the Health and Hospital Corporation Medicaid admin serves as a pass-through from the state general fund of $38 million annually to the Health and Hospital Corporation for care to the indigent. This will cease in state fiscal year 26. And we thank you for this opportunity. Anyone have questions?
Yes, we do have a few questions. This is regarding a couple of slides. It says OMPP presentation seeking to reconcile slide 6 versus slide 16. Slide 6 indicates state fiscal year 2025 year-to-date expenditures are $491 million better than December 2024 forecast. Slide 16 suggests that state fiscal year 2025 year-to-date actual total shortfall is worse than December 2024 forecast. Can you reconcile these two slides, or am I misrepresenting something?
So I'll be happy to speak to this and then turn it over to Leslie as well. So in slide 6, what we're showing are the, oh, yeah, let's go back. Back these up. So in slide 6, what we are showing are the total program expenditures for Medicaid, and portions of these are funded by the federal government, portions are funded by the state general fund or other sources. So I would think of this as the top line number. The expenditures are coming in lower than what was forecasted. The slide that Leslie was speaking to on the funding is really showing how the state portion of that expenditure, the state-funded portion, is being projected. So those are two different numbers.
And while the expenditures are lower than projected, our actual IGTs and federal funding are lower than projected also, right? So, and some of that is a timing issue, as I stated earlier, but the IGTs and federal funding offset the appropriation. So if they're coming in lower than we anticipated, that means we'll need additional appropriation to cover our cost.
This next question is from Jason McManus, and it regards ABA forecasting. What do you attribute the slight decrease in Medicaid FFS ABA expenditures to? Additionally, putting aside cost, what are other states experiencing in the number of recipients for these services in comparison to Indiana?
Okay, let me go back to the ABA slide. I think that was back one. So I think that the first part of the question was that the number of recipients?
What do you attribute the slight decrease in Medicaid ABA expenditures?
So there's a major decrease that we're showing in ABA expenditures for when we implemented a fee schedule in January of 2024. So prior to that, providers have been paid at 40% of billed charges, and we had a pretty wide range of reimbursements. So part of the decrease was related to that fee schedule, but we are continuing to see increases, and they are primarily driven by additional recipients coming onto the program. And there's a lot of national literature about this. I think it's a nationwide phenomenon that more children are being diagnosed and receiving these types of services. And we're going to be doing a lot of work around this to see how our numbers might align with other states as well.
And this question is from Mark Laubacher, OMPP question withdrawal. Oh, actually, no, he's withdrawing his question. I apologize. I do have 3 more questions on note cards.
Hey, Marcus, can we talk about ABA therapy just a bit? So the governor's executive order on ABA therapy instructed us to create a group. That internal working group has been organized, and one of the things they'll be doing is trying to, as Kathy referenced, benchmark our ABA therapy program to other states' ABA therapy program. The difference from what we can tell, the difference between our program and other programs, and well, within Medicaid, nationally, there's huge variation in terms of what an ABA therapy program is and isn't. So we'll be looking at that over the course of the next several months. Thank you.
Okay. A question from note cards. What is the state's plan if there are provider tax changes that will impact half federally?
To cross that bridge when we come to it, because we really, I mean, my colleagues who I sit on with from other states have spent literally hundreds of thousands of dollars modeling different programs. We've modeled at 5%, we've modeled at 6%. Candidly, moving from patient days to net patient revenue, the drop from 5 to 6 to the drop from 6 to 5 it is about, in total, about $100 million of decrease. And that's spread amongst, generally speaking, the larger hospitals, and the state loses out of about, I'm going to give a round number, about $20 million. But we don't know what Congress is going to do. So that gives us some sense of what the possibility may be. But beyond that, we don't really have a plan because we don't have a command.
And I have one final question. What is the state's plans if FMAP changes from the federal government?
Well, that's a pretty broad question. I think what we've indicated is that and I assume the question is about enhanced FMAP for the Healthy Indiana Plan. If it were a 1% drop, you know, we could probably manage that. If they took us back down to the, took us back down to the 64, 30, whatever percentage, that would be a different kettle of fish. From what the drafts that I have been shared with us, they're providing a fairly long runway, one way or the other here. So this is probably a 2027 budget issue. That's my opinion today on the 2nd of May, 2025. But facts could rapidly change that.
Thank you.
Okay, thank you, ladies, for the presentation. And we're back at 2 o'clock with the DMHA review. Well, luckily, that's the last time you'll have to hear that song today. So thanks for all of you for being here. Certainly it's been a interesting morning and afternoon, and we saved the best for last. So Sarah and her team will be out shortly. In all seriousness, if you were listening online, and if you could make it next time in person, I think the folks that did join in person had an opportunity to chat with FSSA staff informally and more importantly with each others. We have several members of the House of Representatives who are kind enough to join us today. So while you'll get the facts and figures, you'll miss the interaction. And we're hopeful that you can be here in person, or I actually will geofence Marion County and the donuts next time, the third time. So we are here to, because Governor Braun asked that we bring back the quarterly financial review for transparency reasons and for accountability reasons. As I've referenced, many of you heard me earlier, the agency has lost its way, right? We had lost our fiscal accountability that's absolutely critical for, most importantly, the people that we serve, and for our providers, and for members of the legislature who need to know accurately and dependably what amount of money they need to budget for us and what they can budget for other vital services that are not provided by FSSA. So today we'll be hearing from our last group, DMHA, and DMHA will be discussing their 2025 spending. We are not discussing our 2026 spending plans, though we will in the future do that. We have perhaps more than any other division inside of FSSA, the operating divisions, the moving pieces at DMHA are significant, and we wish to be collaborative with you as well as being transparent with you. But that is not the purpose of today. If you do have questions that pertain to the presentation, you may address them to that email address, and Marcus Barlow will read them, or you may write them on a note card, and Marcus Barlow will pick them up and read them. So I'll introduce Sarah Saylors and her team to come out and do the final presentation of the day.
right, good afternoon. I'm Sarah Sailors, the Director for Division of Mental Health and Addictions. As you can see, I have several of the executive team with me today. I'll let them go ahead and introduce themselves.
Yes, Lindsay Potts, Director of System Transformation.
Good afternoon, I'm Kelly Welker. I'm the Director of Addiction and Prevention Services.
Hi, Becky Buna. I'm the Deputy Director and Chief of Staff.
Good afternoon. Katrina Norris, Executive Director for the Indiana State Psychiatric Hospital Network.
Here you'll see a breakdown of DMHA's programs that are funded through Medicaid. Our year-to-date actual spend for July through March is $329.4 million. The 2024 forecast for this same time period was $376.9 million, so we have a variance of $47.4 million. The Adult Mental Health and Habilitation 1915I State Plan Amendment serves individuals with serious and persistent mental illness. The goal is to keep them into the community and out of higher levels of care. We are slightly above our forecasted amount due to enrolling more individuals than initially expected. The CMHW High Fidelity Wraparound 1915I State Plan Amendment that is focused on keeping youth in our community and out of psychiatric residential facilities. We're actually over forecasted the amount here due to the utilization of respite care, which was higher than expected. The Behavioral and Primary Health Care 1915I State Plan Amendment includes Medicaid-covered services and adds a service that helps members coordinate health care services to manage both their physical and behavioral health care needs. Inpatient psychiatric, these are Medicaid claims for acute and inpatient psychiatric hospitalizations. The mental health rehabilitation, also known as MRO, which is only billable through our community mental health center network. MRO includes services like the case management, our activities of daily living, and skills training. You'll see certified community behavioral health clinics on here, but Lindsay's going to cover that later in the presentation. Other mental health services, also known as our clinic option services, these are more traditional mental health services, such as individual and group counseling. And then wrapping up the Medicaid programs are our PRTF funds, which is residential facilities that are licensed by the Department of Child Services as a private secure facility and then receive a designation as a Medicaid provider. DMHA only has the responsibility for paying the state match portion for these facilities. And PRTF rates actually increased, which has impacted our spend. Going back a slide. This slide shows our non-Medicaid funding available. And you'll see overall we have $379.9 million. We were forecasted to close out with a balance of $57.3 million. Down at the bottom of the slide, you'll see the federal funding available annually to us is $191 million. Large contributors to the federal funding include such things like substance use prevention, treatment and recovery services, block grants, mental health block grants, and then the state opioid response grant. Year to date, from July through March of 25, expenditures are at $112.1 million. We're forecasted to spend at $171.7 million and a fund balance right around $19.4 million. The state funding available annually to us is $118.6 million. Large contributors to this funding include things like the Severe Mental Illness Fund, the Community Mental Health Fund, and then the Opioid Settlement Fund. Year-to-date expenditures are at $70.9 million. We're forecasted to spend at $103.7 million with a fund balance of $14.9 million. And then finally, you'll see our dedicated
funding includes things like addiction treatment, gambling, and prevention services. Year-to-date, we have expenditures are at $32.5 million, forecasted to spend around $47 million, and with a fund balance of $22.9 million. This slide here just shows how our spend is broken down for this fiscal year, or for this year to date. And so we actually have, you can see that most of our expenditures come from our contracts. We have 512 active contracts that account for just over $190.9 million. And then our services account for a little over $10.5 million. Jumping into some of our programming, our Recovery Works program is designed at diverting low-level offenders from incarceration into community-based services. It was launched in 2016 through House Bill 1006. It's funded at $25 million per year. The funding supports both traditional methods and alternative treatment approaches, such as faith-based treatment. I think one thing to note about this is the appropriation is at $25 million, but we use some of those funds for competency restoration, and so I'll reflect that in a different slide. At the top, you'll see Web Infrastructure for Treatment Services, better known as WITS. It serves around 13,000 participants each quarter. We have our Public Advocates and Community Reentry, better known as PACE, which is our centralized Recovery Works access point. It's our number of referrals. In quarter 3, we were at 915. The Integrated Reentry and Correctional Support Program, or IRACS, is peer services in the jails. It's a warm handoff to a peer on the outside. Quarter 3, we completed 2,741 new intakes, and we served 2,832 participants. And then at the bottom of the slide, we have Unite Indy, which is door-to-door transportation for individuals with a felony from their home to their place of employment. We have 6 employers this quarter participating, and we served 97 participants using 18 vans. Recovery Works programming is all funded through state dollars with no federal or dedicated funding. Year to date, expenditures are at $12.5 million. We're forecasted to spend $18.9 million, and we'll have a fund balance around $4 million. Moving into the competency restoration, this is mental health treatment and legal education for individuals who've been charged with a crime and found by a court requested competency evaluation to be incompetent to stand trial. This is typically due to either mental illness or intellectual disabilities. Our referrals for this program, as you can see, continue to increase at a rapid rate, and it's been very challenging for our state hospitals to keep up with the need. In 2024, we had 613 referrals. To ensure that our patients are able to receive services timely, we developed alternative restoration pathways so that services can be received in other locations outside of state psychiatric hospitals. We have 2 pathways. We have jail-based restoration, which we have in Tippecanoe County and Vanderburgh County. We also have 3 inpatient options with contracted providers. We use Valley Vista, Wellstone Regional, and Hendricks Behavioral Health. In March, we had 35 active patients. Our annual contracts run around $15.8 million, and our year-to-date expenditures are at $9.4 million. Competency restoration programming is all funded through state dollars, no federal or dedicated funding. Year-to-date, July through March 2025, we're at 91.1 million, I'm sorry, 9.1 million, with a forecasted spend at 13.1 and a fund balance of around 676,000. This time, I'll turn it over to Lindsay.
All right, thank you, Sarah. And I have the privilege of talking about the Certified Community Behavioral Health Clinic Program overview. So Indiana was excited to be a part of the demonstration starting this calendar year on 1/1. Provider sites, as you can see in the map here, serving those highlighted counties in Indiana. A couple of things to call out. A part of the demonstration is the 21 required quality metrics and goals. And so this is a program that is a high quality and high visibility program. We also have the programmatic and site-specific service mix goals that align across the 9 service categories you see in that box there. A couple of categories to call out are our crisis services, also outpatient mental health and substance use services, and our peer services are among those 9 services that are offered to anyone, no matter their diagnosis or ability to pay. And so Indiana, we have our emerging data that we just came out with. This, of course, is very preliminary since the program is brand new. So it started just a few months ago. And so we're still collecting and working with sites, however, have high confidence in this data that we're presenting today, which is that there are a little over 30,000 unique Medicaid members who have been served by CCBHC in Indiana just in this first quarter alone. What we also see is the change in access, and so CCBHC is an increase in access to behavioral health services, and so we monitor timely access not only to that first appointment, as you can see there on the left, but also to the follow-up appointment. And you can see the comparative data over the years and see the comparative data this first quarter against our community mental health center network. We will also have additional quality data in the coming months of the program as those 21 metrics start to mature and we get that data as the program is implemented. And now transitioning to our 988 crisis response system. So this is our map here, and just to specifically call out the 3-pillar system, we have our 988 contact centers. We have 5 of those call centers, 4 call centers, 1 text to chat. They serve all of Indiana. And so if a call comes from Indiana, it is answered in Indiana, and I'll show you in a little bit that answer rate for those calls that come from Hoosiers. We also have our designated mobile crisis teams. We have 21 different providers serving over 90% of the state. You can see that in the highlighted blue areas, only a few holes we are still working assertively to fill, so we have 100% state coverage for mobile crisis. We then have our crisis receiving and stabilization services, where we have 21 sites throughout the state, serving individuals as a safe place for help as a diversion from criminal justice involvement, and also our emergency departments and hospital systems. Our data here for our 3 pillars, as you can see, have compared this from the same quarter last year to this year. We've had exponential growth in our calls, and so 988 is continuing to be socialized nationally and also in our state. So that way individuals know that this is a trusted line to call in a mental health crisis. And as you can see, as our numbers have grown, we have actually increased our percentage of answer rate. So this means that when a call comes into the 988 system, if that caller is calling from Indiana, it is answered by somebody in Indiana who's familiar with our crisis network. And then you see with Pillar 2, similar trends. We see that mobile crisis response continuing to increase. Our providers have stood up an immense amount of services in a very short period of time. And so really the last year to 2 years has been this exponential growth in access for those individuals who are experiencing a mental health crisis to have a certified team come out and respond. And you can see that the number of calls and then the line there is the unique number of individuals that are served. So we do have some folks utilizing this service multiple times, which is to be expected. And then we have Pillar 3, which is our crisis receiving and stabilization services. Again, similar trends. We see the numbers continually going up, and this is what we would expect to see as the program has grown and matured. And again, you can see the unique individuals. We have a lot of individuals coming back, which is a good thing. We want to see folks who are in crisis continuing to utilize services that they trust. And so that unique number is called out there. I do want to note that these numbers are our lowest estimates for this quarter. We still had some data coming in as we're continuing to become more sophisticated with how our providers report this data into our systems and how we report it back out to you. Okay, so just a bit of a snapshot of our funding. And so our year-to-date expenditures are $45.5 million. This is blended funding. As you can see, there's both state and federal dollars that we have combined together to build this program. So just something to call out on what this funding has been used for in the last year is to build a lot of the infrastructure necessary for our crisis response system. So those startup costs can be quite a bit larger than ongoing costs. And then we can see there that our forecasted funding that we're still going to spend is that $58 million, and then we show a fund balance right now of $9.7 million. I'm also going to cover our seriously mentally ill and seriously emotionally disturbed funding summary. So these funds are used to serve some of our most vulnerable in Indiana. And so these are individuals experiencing a serious mental illness with severe functional impairments. These services allow for them to regain skills regarding daily living, interpersonal functioning, adaptation to change, and then those key things on concentration, persistence and pace, similar programming for our seriously emotionally disturbed, which is our SED for youth. So those services are called out there. Just a couple of programs to highlight. These funds really are focused on a population of service, and some of the programs outside of our Medicaid rehabilitation option include our first episode psychosis program, which is for those individuals experiencing psychosis for the first time, and those early intervention programs that are very effective. And for our youth, this is our Encompass program, which is similar for youth, which is serving the complex needs of individuals that have conduct and addiction needs. Really want to underscore that this is really an area where DMHA uses evidence-based practices and emerging practices to serve individuals in our state to address those more serious and acute needs. So our program summary here, as you can see, that our year-to-date expenditures are $50 million. Again, this is blended between state and federal dollars, which come in block grant dollars from the federal and then our state appropriation to serve these populations. That, again, supports our Medicaid rehabilitation option and also supports other programs with our block grant dollars. And then the total forecasted we have there is the $75 million with an expected fund balance of $10 million. I will now hand it, just kidding, one more. So our seriously emotionally disturbed program summary here, very similar braided funding there with both state and federal dollars, and supports those programs I spoke about, our Medicaid rehabilitation option. And is expected to have $20 million is the forecasted expenditures with a forecasted fund balance of $3.1 million. All right, now I will hand it.
All right, thank you, Lindsay. I'm going to start off talking about some of our federally funded programs and state-funded programs. So we have kind of a mixture. Highlighting first our State Opioid Response Grant, also known as SOAR. And just highlighting a couple of the initiatives that we fund through that is we help provide funding for people who do not have a third-party payer or a denial of payer to receive substance use disorder treatment, as well as recovery residents. So if somebody completes treatment, they need a safe place to go to live afterwards. This gives them a little extra structure. We will help pay for their room and board while they're in that recovery residence. We also partner with Overdose Lifeline, who is our naloxone distributor, and they will provide naloxone to laypersons, local health departments, community supports. So naloxone is available free of charge to anybody throughout the state. Highlighting our Substance Use Prevention, Treatment, and Recovery Services Block Grant, also known as SUPTERS. We have a lot of acronyms here, so I will say them out first, but that is our SUPTERS grant. What we do with that is also provide some residential treatment services, funding for that. We provide the ASAM 3.1 level of care, which is the low-intensity residential, as well as the ASAM 3.5, which is the high-intensity residential of care. And that is for patients who are at 200% below poverty level, and also our priority populations of pregnant women or women with dependent children. And then lastly, a couple of our initiatives with our state treatment funds. We help support the CHOICE program, which is through Community Hospital. This is for pregnant and parenting women, so it starts prenatally and goes postnatally and helps them throughout their journey and their pregnancy, providing peer services, access to their medical care that they need. And then we also provide funding for Lyft rides through 211. So this is for individuals who need access to transportation to get to those treatment services or get to those recovery services.
Can I just comment on, this isn't necessarily about you, but the number of programs that FSSA operates with the same name that are different is just stunning, right? We have 2 PACE programs, we have 2 CHOICE programs, we have 2, I mean.
I absolutely agree, Secretary Rowe.
We have no creativity, apparently.
We do need to work on that. And highlighting some of those metrics that I just talked about through those funding. So through our Lyft rides through 211, so far through SFY 25, we have provided 838 rides through that. Number of participants who received services in recovery residents through our DEB system, again, another acronym, that's our DMHA electronic billing system. So far to date through SFY 25, it's been 1,459 people. Number of participants who receive substance use disorder treatment as well, that has 4,376. And then lastly, I think, which is phenomenal, is the amount of naloxone that has been distributed so far through SFY 25. We are at 235,722 doses to date so far.
Okay, so this does not reflect the HIP patients who are receiving third-party substance use disorder treatment.
Correct. These
Right.
are for people who do not have Medicaid, have no other third-party payer.
So for the next MFR, let's try and incorporate an addiction services slide for all payers, right? All state payers.
Okay, and we do have that information. We have pulled that together from our previous MFR, knowing that's what you wanted, so hopefully we'll be ready to go for you. And moving on to the funding for that.
I'm sorry to keep coming back to this point, but the reason I want that slide is that the number of, this significantly underestimates the size of the problem, right? And I want to be able to demonstrate effectively the size of the addiction problem. And if you just looked at this slide and believed that's the answer, you wouldn't have near the concern that you should. Not you, but.
Yeah, no, I agree, and we have worked very closely with Kathy and Leslie at Medicaid to make sure we have those numbers moving forward. Okay, moving on to the funding for our substance abuse treatment. You can see so far total forecasted expenditures were at just over 79 million, and a forecasted fund balance to end with just over 6 million. So some of this that the funding goes to is contracts and grants and social services payment that goes for those treatment services, recovery services, peer support services throughout, as well as some jail treatment services. Moving on, also as part of the addiction and prevention team is our gambling services. So our funding from that comes from a admissions and supplemental wagering tax, as well as a portion of the sports betting tax that we receive each year and goes into the addiction services fund. We currently have provider agreements with 13 agencies that provide treatment and education services for gambling. Also help fund and administer the problem gambling helpline, and provide oversight to statewide partners that address problem gambling issues. And moving on to some of the metrics for that. So far through SFY 25, over 2,212 people have received services for problem gambling. We have had 528 people who have had new intakes so far. We also have, I don't know if everybody's familiar, there is a voluntary exclusion program that people can voluntarily exclude themselves from Indiana casinos. You can do that at the casino, you can do that through your treatment provider. So to date, through SFY 25, 427 people have done that. And then we also have, since sports betting came legal a few years ago, there's also now an internet self-restriction for sports betting. And to date, through SFY 25, 83 people have enrolled in that. And then lastly, for the problem gambling helpline specific calls to date, 534 people have utilized that hotline for problem gambling services. And just a summary of the gambling funding that we have. So far, the total forecasted expenditures were just over 2.3 million, and looking at a forecasted fund balance to end just over $1.1 million on that. And so that supports those services, those gambling education and treatment services through the providers. Moving on to the prevention side, you can see here the map shows where all of our prevention programming providers are currently located throughout the state. As part of the SUPTERS, or the Substance Use Prevention, Treatment, and Recovery Block Grant, there is a 20% primary prevention set aside that we must hit each year. So some of those programs that we use is evidence-based programming for school programs, for after-school programming for kids, as well as programs for adults, parents, and families that educate and build parenting skills, substance-free events and social messaging for college campuses and throughout the communities, and then well as educate the public on underage drinking and substance abuse prevention on college campuses. And moving on to the funding specifically for prevention, currently to date, the total forecasted expenditures is $15,396,148, with a forecasted balance just over 1.5. You will see just a couple of brief spots in red for the salary and benefits. So staff fund their code to a specific funding stream. And at some point, we do hit that 5% admin cap, so that will be shifted on the back end to a different funding stream, so that red will no longer be there. Moving on to one of our newer and biggest funding streams that we have is the opioid settlement funding that we have received. So currently, Indiana is set to receive $980 million over the next 18 years from the National Opioid Settlement. And this is from different pharmaceutical companies and manufacturers. All the information is housed on the Attorney General website, which has all the financial updates, all the settlements, all the funding for the opioid settlement, as well as we have highlighted the Indiana code that defines the distribution of the funding. So it's a 50-50 split, so 50% comes to the state, 50% goes to the local municipalities. And then there are the abatement funds that are obligated based on Exhibit E. So Exhibit E is very lengthy if you would like to check it out, but that is all the allowable expenses to use those settlement funds for, as well as we do have an Indiana opioid settlement update website, that has all of our state plans that have been approved for how the state funds will be used, as well as the recommendations for the local governments to use their funding for. And just to add to that, there are 648 local municipalities that receive that funding, with 35% going to the state abatement opioid settlement account. So that goes strictly towards programming for the treatment, the education, and recovery for that.
Local side of the 50-50 split, what percentage of the locals have actually spent their dollars?
So reporting-wise, we've had 644 out of the 648 report. Not all of those have spent, but we have worked very closely with a vendor who are working with the municipalities, and with the new recommendations of how to spend that funding that was released in November of 2024, we are very hopeful that they will start spending their funding.
Okay, so give me a ballpark figure of what it was. Last time you checked, what was that number?
Of how many municipalities that had spent money?
Not had spent money, but had spent, well, okay, had spent money.
I would say out of the 644 that reported, we had at least about 50% that had spent some money.
So that means 50% haven't spent any of their money. Yeah.
I was trying to make it sound a little bit more positive, but.
You're dealing with me, there's no need to. Okay, well, I mean, I think that at some point, the General Assembly needs to revisit that question of whether or not, because that money's just sitting there.
And we have encouraged local communities, so if they receive 5,000, to partner with, it's a town, to partner with their county and really build on kind of making full advantage of kind of regional spending that money as well. And moving on to the funding summary for the opioid settlement. So here, once again, you'll see just a couple places in red. So we have decided to, for the salaries and benefits, that all admin will be going towards the state unrestricted funds. So that means all the abatement funds will go strictly towards programming. So that will be shifted on the back end, so that red will no longer be there in the salary and benefits. And then the one red within the grants, we thought that initially was going to be a grant, but it was actually a contract, so that will be switched, so that red will be gone as well. So currently, totally forecasted just over 31 million, and then a forecasted fund balance of just over 20 million right now. Okay, moving on to our opioid treatment programs, which is known in legislation as methadone clinics. So we currently have 26 throughout the state, so that shows a map of where all of our facilities are located. We currently have, like I said, 26 certified throughout the state. They provide a multimodal approach, including medication, counseling, and other supportive services. They must meet DMHA certification requirements, which I have listed there, the 440 IAC 10, comply with federal and state laws through SAMHSA, so the Substance Abuse and Mental Health Services Administration, the DEA requirements, as well as the Indiana Board of Pharmacy, and then also be accredited by a national body. So I'm going to start talking on some of these numbers here, but also want to highlight something that Secretary Rowe mentioned earlier. So these numbers that we serve, the patients served, are strictly through our programming only through the opioid treatment programs or the methadone clinics. So this does not fully capture all the Hoosiers that are receiving medication-assisted treatment throughout the state. These are just the ones in our program. So currently, unique individuals that have been served is roughly just over 11,500 each quarter of this year. Admissions through SFY 25, we've had 4,336. Discharges, we have had 3,894. And then quarter three, we have the average miles of travel time for the patients, and that's at 15 miles. So with our Lighthouse system, which is where we track all of our data, it's a point in time, so we were not able to get a full complete for SFY '25, but it averages out about 15 miles for each patient. All right, moving on to this slide, you may notice a lot of red, but there is a very good explanation for that. At the bottom of the slide, you can see an Indiana code that is cited 12-23-18-3. So this is legislation that has been put in place where we are able to bill back to the providers our services and our admin for that. So in 2008, there were 13 opioid treatment programs. In 2017, we were allowed to open an additional 5 opioid treatment programs, and then in 2019, an additional 9. So we have grown from 13 to 26 OTPs during that time frame, which has allowed us and the need to grow our staff, which has expanded the need and the increase in budget. With that, everything that we have, we charge back to each OTP at the end of the year. So at the end of the year, the net forecast ends up being a 0 balance. The budget bill has stayed the same as the appropriation for numerous years.
So just so you, to put it in some broader historical context here, back in the mid-90s, the state of Indiana had a single opioid, methadone clinic. So that's a huge
increase in
increase
jobs,
over
yes.
30 years.
Yes, so roughly each year, the budget bill, I want to say, is about $471,000 for our opioid treatment programs. And since that expansion, that it shows why the initial forecasted fund balance. But again, at the end of the year, that gets charged back to the OTPs and it will end up being a net 0 balance. And I will pass it along to Becky.
Thank you, Kelly. So I'm just going to highlight here, this is the DMHA central office. And so what you see here are the salary and benefits for the staff within our office. And then the contracts as well as the grants identified here, these are actually contracts and grants that help cover state hospital network system. So their Cura Foods, their Cerner, and some other contracts that they have that are covered through the DMHA admin. The admin operating and the other admin expenses, as many other divisions have mentioned, these cover the travel costs and IoT, and like others, there was an increase in the IoT costs that was unexpected. So you will notice, and Kelly referenced here on the federal funds, that a lot of our federal grants have a 5% admin cap. And so on this, we have a state balance that is overdrawn. Again, Kelly also referenced this. When our staff enter their time, they enter it to the general state appropriation, and then we need to switch that on the backside and make sure that we are adequately billing federal grants up to as much as possible, the 5% admin cap on that. So these are the high DMHA contracts. I just want to put a note out there that several of these items include multiple contracts, and at the same time, DMHA has over 500 contracts, which I believe we are the highest division within FSSA, not that it's competition or anything. So the first line here is our community mental health centers. And so Lindsay, when she talked about the SMI and the SED funding and to assist with the match, these contracts cover that. So it's 24 community mental health centers. It helps to ensure that as the required gatekeeping and safety net services are all provided within those community mental health centers. Intacare this contract has not been referenced yet. It's the mental health funds recovery, and the amount was on the Medicaid slide that Director Saylor shared earlier. This is, as you will see, mostly federal funds, And this is where InteCare works with, again, our Community Mental Health Center network to assist in those community mental health centers to provide services on behalf of the state related to Medicaid. So an example is that as a Medicaid provider, you cannot bill Medicaid to enroll someone into Medicaid. Well, this is an administrative fund that allows some funds to support those activities, and so they are acting on behalf of us. The call center contracts and the mobile crisis and the crisis centers, this is a group of each one of these sets of contracts. Lindsay already went into a lot of the detail on this, so just so you know, this is what those contracts total. So there are multiple agencies within each one of these lines. The CREATE contracts also have already been referenced. They are part of the competency restoration, and these are the public-private partnership with some hospitals to assist our state hospital network in getting access to competency services to hopefully bring down that wait list when they didn't have the access. The Mental Health Association of Indiana, this again, it has been referenced. This is utilization of Recovery Works funding. This is the integrated recovery and support services. This is peer services in the jail system. This requires a partnership at the local level between the sheriff, the jail, as well as a certified recovery community organization to allow a person who is in jail get access to peer support and then have that transition to peer services as soon as they get out. IHCDA, this is the Indiana Housing and Community Development Authority, and we transferred through a memorandum of understanding, $10 million. This is opioid settlement funds. This again is a partnership where IHCDA put out proposals and partnered with our provider network to build recovery housing and housing that allows for individuals with substance use disorder needs. There's 4 entities that they partnered with, $2.5 million each. And so this is another partnership where individuals that have substance use disorder can get access to housing as well as the services and supports to increase their chances of success. And then Black Onyx, this is our mobile crisis accelerator program. And this is an opportunity for smaller local folks to get access to funding and training and support in building out their mobile response teams. And so they just released their letter of intent and identified some providers, and soon we'll be moving forward with awarding funds to some of those providers to build out the mobile response teams. So I want to highlight our quality assurance and quality improvement team. We have a team at DMHA that has the responsibility not only for certifying all of the providers that we oversee at DMHA, but also for doing the site visits and the audits. So just a note, we have 689 providers within our system. That is total across the board, from community mental health centers to residential to our opioid treatment programs. And part of their responsibility is to review all complaints and investigate complaints that raise up to a certain level. And so far in this state fiscal year, we have received a total of 150 complaints. And also the team is responsible for reviewing critical incident reports, and we have 619 of those that we have received so far this fiscal year. So you can see the trends here. These are just some trends that they have identified as they go out and do their reviews. What I would say is the most common theme across all of these trends is documentation, documentation, documentation. And so what they find is that treatment plans are not meeting the needs, they are lacking signatures, there's releases of information that are incomplete or don't have signatures. And so those are just some of the major trends, and our focus in the future is to provide additional training and support around these. So this is just some data to show, and this is just from the third quarter of state fiscal year 25. And I just want to point out this is broken out by teams. So the private mental health institutions, these are the acute or inpatient facilities that we oversee. We are required to do unscheduled visits. So those are, we show up one day and you don't know we're coming. And so all of those are unannounced or unscheduled. And then this just goes through the number of visits that were conducted for each one of these areas, and then the critical incident review, and then the total number of corrective action plans. As you will see, we do a lot of corrective action plans, and so it's not necessarily a bad thing. It is a way for us to work with, side by side with a provider to say, hey, you're not meeting the standards next to our code. How do we work with you? How do we help you to get some tools and resources to get to a better place? And then conditional status is just what it is. We place conditions upon their credentialing. And then we did terminate one outpatient provider during this time frame. Also, recovery residences, we do certify those within that same team. And then also on this slide are the opioid treatment programs and recovery works. And so we also, outside of our QA team, the opioid treatment program team, as well as the recovery works team, does site visits, and so this is a snapshot of that data. And then as far as the DMHA staff, again, this is referencing central office. We have 114 positions that are available, and out of those in Q3, we had 99 on average that were filled. We do have some contract positions. These mostly help with our disaster response teams because they make more sense to be out there in the field, and we have 7 of those.
Thank you. I'm in a really odd spot, so it's kind of hard for me to see the slides. So I'm going to do my best. Bear with me, and thank you all for staying to the end here. Okay, so the State Psychiatric Hospital Network program metrics summary for occupancy are here for each quarter of the state fiscal year. I think you can see the quarterly data reflects that the State Psychiatric Hospital Network has been consistent throughout the state fiscal year. It also reflects the ongoing demand for our services that we are still waitlisted for admissions. Specifically, the third quarter data report shows that the state hospitals are at the following occupancy rates. So for the Children's Center in Evansville, 83%. Evansville State Hospital is at 89%. Logansport State Hospital, 75%. Madison State Hospital at 86%. And Richmond and NDI closing in collectively together, 93% each. So for informational purposes, we have 770 operational beds throughout the state, and as a network as a whole, we're at 87% occupancy. So for those of you who work in healthcare, you might look at that and immediately go, that's outside of the standards for healthcare, the healthcare industry. It's dangerously high occupancy. Again, the demand for our services is there. So we not only have that moral obligation to treat, but we also have a legal obligation to treat. All of our clients outside of youth are court-ordered either civilly or forensically for our services. So we continue to meet that demand to the best of our ability. And this is a snapshot in time for the average length of wait in March. And each hospital is broken down based on patient populations. And again, like Kelly mentioned, we use a lot of acronyms, so I'm going to try to share those with you to avoid additional confusion. So the average wait times for each patient population reflected on this slide are a snapshot in time on March 31st. Our co-occurring population, which is individuals who have a severe mental illness as well as a substance use disorder, was on average 27.5 days. Our forensic population on that date and time was 17.6 days. Our youth, or SED, at that point in time was 48 days, and severe mental illness, or SMI patients, were at 49.5 days average wait. It should be noted, though, that the forensic wait time specifically to get into a state psychiatric hospital may be much higher than that, but because the use of the contractual alternative restoration providers, it lowers the overall average for forensic clients. And we are grateful for that partnership. This is just a really simple breakdown of what our current patient population is within the state hospitals. So you can see there, 52% are forensic, 38 are civil adults, and 10% are youth. Specifically in this quarter, we saw Richmond and Evansville both exceed 50% forensic patients, and I believe that it was the first time in Evansville state history that they ever exceeded over 50% forensic patient populations.
So I may have asked you to do this, and I'm not sure you have I think you told me you didn't have the data, but my recollection from my last tour of duty here is that forensic number was pretty much just at Logansport, and maybe 18 or 20% of the population. So that is a significant change. Steve McCaffrey may have a better sense of that than I. Is he still here? Yes. Is he awake?
You're correct in terms of your trend line. It's over.
Yeah, okay, well, thank you. That's coincidental, it's not causal, I don't think.
And Secretary, the competency crisis is in fact a national problem. And the state psychiatric hospital leadership team has worked very closely with the judicial branch through the Indiana Supreme Court's Office of Behavioral Health to implement the recommendations from the National Center for State Courts to divert Hoosiers that may be safely restored within their home communities, thus opening up space for those who need a more intensive level of care but are caught in that competency process. A lot of these individuals not only come to us with their psychiatric conditions, but additionally very complex medical treatment or medical conditions that are untreated as well. So we want to save our resources internally for those that are more complex and difficult to manage. So these are our largest contracts across the network. Again, no surprise, anyone who works in this field, staffing, medication, food services, and electronic medical record are obviously very costly, but they are also very necessary in hospital operations. And I can go through those individually if you would like and explain them, but I do want to just remind everyone that we have a very highly regulated environment. The hospitals operate with very prescriptive staffing requirements for certain roles, such as registered nurses and psychiatrists, as well as our Joint Commission accreditation, which guides us to operate within the safest healthcare industry standards, and they come at a cost. So this cost is necessary to provide the best care for the most vulnerable individuals in our state with severe mental illness. And ultimately, we know that the clients we serve are expensive, and every other system has failed them if they end at this level of care in this part of the continuum. So certainly costly to take care of the patients, and the contracts are listed there. I'm open to questions if anyone wants me to go over each line of those contracts. Staffing is listed here for you as well. So it's our largest expense, like most other industries, but it displays the staffing across the entire network. It is divided there between state staff and contractual staff. And so I really want to point out that we have done a remarkable job with that sharp decrease in contractual labor over the course of this state fiscal year. And really the credit goes to the local leaders. The superintendents have led the charge to reduce their use of very expensive contractual staff. And I'm incredibly proud of those efforts. So to date, we have 1,709 state employees and 42.5 contractors within our state psychiatric hospital network at all locations. Continuing forward here with what we are doing internally, some initiative updates, if you will. We have really worked diligently to look at cost savings measures. And so the team and I are in full swing implementation of these efforts at every location, which include a manning table review to basically take vacated positions and give them back so we're not paying those costly seat charges. Each location has looked at an analysis of their operational services. To simplify that, it's really looking at any place we could save funding by contracting collectively and consolidating services, doing budget analysis. Is it cheaper to maintain operations internally with state employees, or is it cheaper to contract? Because there are times where it is. And then again, consolidating and sharing services where we can, which we've learned to do very well. The pandemic taught us a lot of lessons, and primarily it's that we're better together. And I already spoke to the reduction of the contractual staff across the network. I'm going to pause for a second and take a deep breath before I share this next slide with you all, because it's incredibly red. And in full transparency, there's some history to how we got here. This, at first glance, this forecast for our hospitals looks very grim. So I think in fairness and transparency, we need to start by addressing the increased patient volume and the hospital occupancy rates that have driven the cost beyond our appropriation. So the network has experienced a significant increase in volume and occupancy over the past 3 years. To put this in context, as a network in calendar year 22, we were at 68% occupancy. When we closed calendar year 24, we were at 87. So combined patient days, that's an increase of more than 50,000 patient days where service was provided across our network. If you know, or if you have access to, our appropriations have been relatively flat with minimal increases over the past decade. The funding did not account for the increased operating costs during the pandemic, during either of the previous 2 bienniums, nor did appropriations account for the increase in patient volumes in our current biennium. So despite the lack of increased funding and the increased demand, the system was able to absorb those 50,000 additional patient days in 2024 alone. And despite the financial and operational strain, I remain proud of my teams because they could show up every day and demonstrate the ability to meet the mission to serve Hoosiers with severe mental illness, as well as the children in our state who are suffering with the most serious emotional disturbance. Our forecast is not a result of egregious spending or waste or poor management. It is simply the result of the strain and the demand within the behavioral health care space today. So historically speaking, we wouldn't ask the legislator to give us more money. Instead, we would say, let's show the need, let's demonstrate the need, and we can always leverage the mental health funds, because historically that was an option for us to do so. And all revenue that is collected within the state psychiatric hospitals does go directly to the mental health fund. Probably Steve and Zoe would be the only ones in the audience today that would understand the IMD exclusion for our billing capacity. And Stephanie, sorry. So our expenditures are outlined here as well. Again, they're really not surprising for anyone that works in this space. Staffing, food, medications, psychiatric drugs, and the complex medical conditions of our patient population are very, very expensive. In addition, you've seen our contracts and our electronic medical record cost. So those expenditures are not outside of the norm. Hospital employee compensation in the United States rose 45% between 2014 and 23, according to the American Hospital Association. The gap between the state's wages for key positions and what other health systems around the state were offering became so large during the pandemic that as a network, we accumulated hundreds of vacancies and risked losing our CMS certification due to unsafe and minimal staffing requirements, to the degree that we had to bring the National Guard in to assist us to care for the patients that we are ordered to treat. But to address those problems, the State Psychiatric Hospital Network did what other health systems did across the nation at that time. We worked with contractual labor at an astronomical cost. And that's how we met the needs of the people that were in our system. So in fiscal year 24 and 25, you saw the demand for our services continue to increase with much sicker patients, more complex conditions. A shorter forensic time meant more acute patients that did not have access or refused the access they had to psychiatric medicines in the jails. So they were sicker, and we were seeing them more frequently. Our teams continue to stay prepared to serve the nearly 13.5% increase in volume that the trends are telling us, all the while reducing our operational cost for patients served in our system, which would basically buck the norm amongst national health care trends. But I'm confident that I have the team to do this. So each individual hospital has special needs based on the populations they serve, as well as their buildings, their campuses, and their infrastructure, and the communities in which they are placed in. So I am going to show you each individual business unit, each state hospital's specific Q3 data and projections in the coming slides, what it looks like for us. So this is Evansville Psychiatric Children's Center. There are 20 operational beds at the Children's Center in Evansville, and you can see there their projected shortfall is about $1.2 million. All of our sources of funding come from the state appropriation and the mental health fund augmentation in which we are able to access. I don't think there's going to be much difference between the slides as far as the expense categories that are broken down there, but I certainly welcome questions for any of the locations.
Okay, let me make sure that I have this correctly, right? So each of the children who are located there are Medicaid eligible, right?
Correct.
So we bill Medicaid for them, we put up the match, we pull the money down, but that funding goes into the mental health fund.
Correct.
Okay, I just wanted to make sure that the audience understood that we are billing.
Yes.
We just don't bill, we don't credit it back to the hospital.
That is absolutely correct. Thank you, Secretary. At the Evansville State Hospital, the close of financial reporting, March 31st there, you can see that $2.7 million shortfall for the state fiscal year. And again, the expenditures are the same across the board with staffing, overtime, utilities, medications, et cetera. Madison State Hospital, in our projection, forecasted balance is about $3.9 million shortfall for the state fiscal year. And again, there's nothing different at each location. They all have the same expenses, they just have to spend it differently. For example, an older campus such as Richmond may have some more expenditure on infrastructure than a newer hospital like the NDI, who doesn't have generator problems as frequently. Logansport State Hospital, close of Q3 forecast looks to be $10.6 million shortfall. Logansport certainly treats a different patient population. They have housed the state's only maximum security forensic unit, and they treat only forensic patients at Logansport. So they have more staff than some of the other locations because of the acuity and the risk associated with some very high-profile forensic cases that we treat. Richmond State Hospital, at the close of this quarter, projected shortfall at $2.6 million. Richmond's done an impeccable job of keeping things going in a very old campus and still treating 93% occupancy patients. So certainly appreciate all of the work that's been done there. And last but certainly not least, the Neurodiagnostic Institute financials here showing the projection for the quarter to be at right around $4 million shortfall. The Neurodiagnostic Institute as well has maintained that 93% occupancy. So just in a few years, they went from a few floors open for business to now, I think this morning they were -2 on beds offered. So we continuously are running folks through to the best of our ability and meeting their specialized needs. Thank you for this opportunity, and I am supposed to open to questions, correct, ladies?
You got it.
All right.
Thank you. Nothing? We'll take it.
Before we leave, I do want to, this will, unfortunately for us, be Lindsay Pott's last appearance. She is leaving FSSA, and we are grateful for her, the time she spent with us and for her leadership. So thank you very much for your time. All right. Do we know when we're doing this again? Eric? Eric's not in the room. Okay. So we'll do this sometime in mid-July, and looking forward to that. Thanks so much for being here and your participation.